people that want to have
conheçam.
access
E
know.
estamos agora
And
também, né,
now,
até o dia 15 de dezembro, já vou aproveitar
until
aqui para
December
fazer a
the
propaganda,
50th,
né,
I
estamos
would like to
abertos
take this
aí
moment
às
to make an
inscrições para o Laboratório de
advertisement. We are
Inovação
opening for this
Latino-Americana de Práticas de
subscriptions of
Participação
the
Social em Saúde, que com
innovation
certeza irão
lab of
aparecer
the health
novas
practices,
experiências
and we are going to
positivas
have
no enfrentamento
new
à
positive
Covid-19. Nós ainda temos
experience to
muitos
fight
desafios pela
COVID-19. We still
frente,
have a lot of challenges
precisamos
ahead,
intensificar o
and
processo de
we need to
vacinação. Por
intensify
isso,
the
inclusive, lançamos
vaccination
aí na
process.
OPAS,
So
né,
we
com o
launched
CONAS, CONASEMES
here in
e
Parro,
a
CONAS,
própria OPAS,
CONASEM,
o Conselho Nacional de
and
Saúde, a campanha
Parro
Vacina
itself,
Mais, para a
the
gente poder
campaign
resgatar
Vacina
os níveis
Mais, so
históricos
we
do
can
nosso Programa Nacional de
rescue
Imunizações
the
e
National Program
continuar
of
fazendo com que as
Immunization
vidas
and
estejam em primeiro lugar.
make the
E como diz
lives
aí, né,
Brazilians'
o
life in
tema
first place.
da
And
própria
as
OPAS, nos seus
the
120
theme
anos,
of
não deixar
Parro
ninguém para
says,
trás.
120
Então, um ótimo seminário,
years do
forte
not left
abraços
anyone
e até
left.
daqui um pouquinho, porque de tarde deve
Big
estar
hug to
chegando por aí.
you from the Sul, and thank you very much for the opportunity.
Isso. Bueno, obrigado, Fernando.
Thank you,
Bueno,
Fernando.
aquí con las
Well,
palabras de Fernando estaríamos
now
dando...
I'll give the floor with the words of Fernando. We are closing this panel. We are going to have the opportunity for questions related to this initiative, and I would like to highlight in this way of doing things like Brazil does when we talk about clinical research, but we support ANSUS in its structure, governance, and I believe that we are doing things better. I would like to thank and greet everyone, but we are following this initiative, and nowadays, unfortunately, he could not be here, and now we are going to go to the next activity. We would like to hear is with us in the virtual way, Saisun, Director of the Evidence Department. I would like if you hear us. Technical team, can you put in the screen? He said that he could not, and he is in Geneva in another meeting. So we are going to following with the activity. As you know, today we have a Brazil match at 4, and because of this match, all the activities necessary are new programming. So we are going to adjust to end at 3:30. We are going to follow with the panel that are going to talk about the global strategy for clinical research on COVID-19 and long COVID challenge and lesson learned. And we are going to have 40 minutes for that. One of talking about the international panorama, and each of them with 20 minutes. So we have the privilege to hear Silvio Bertagnolo that were with us, and on site we are going to have Ronaldo Silva. I would like to invite them to take their place at this stage. Ronaldo Silva is statistician of the WHO Global Clinical Platform, Department of Culture Readiness, Strengthening Health Emergence Program, Department of Sexual Reproductive Health and Research. Please be welcome to our stage. Is with us Dr. Roberto Hidalgo, Health System and Service Coordination. Now we have the panel.
Hi everyone, and I hope you can see my slides.
Dr. Silvia Bertagnoli, is she with us?
And Perfect. So thank you very much for inviting me again to present today to you the.
Perfect.
Can you
Let's
see the
start
presentation?
with Dr. Tapia, where while we are articulating
Can you see
this
the
technical
presentation?
issue, so we can hear Dr. Sylvia. We are going to have this privilege to hear about Dr. Tapia.
Can
Please,
you
have the floor.
please confirm that you can see my slides?
The presentation, please. Dr. Sylvia we can hear. It's through internet, and in the local we can't hear. While the technical team is adjusting, we are going to hear Dr. Tapia. Is that right? Now is your presentation, Dr. Tapia. Well,
De la estrategia y cómo esto fue abordado desde el punto de vista de Brasil, cómo enfrentamos el desafío de establecer esta red colaborativa ya desde mediados del año 2020. Por favor, la próxima.
Next one.
¿Me pueden dar la próxima, por favor? Pasar a la siguiente slide.
Please, the next slide, please.
Eso. Bueno, aquí vemos un poco para situar en contexto la cronología de la pandemia del año ya 2019, 31 de diciembre del 2019. Estas son extractos de la página web de OMS, tal como OMS hoy día presenta las noticias de aquel momento. Ya 31 de diciembre, la Comisión de Salud de Wuhan reportaba un clúster de algún tipo de neumonía, ¿ya? Decía era posible que eventualmente un nuevo tipo de coronavirus fuera identificado. El 4 de enero del 2020, ya ha cambiado el año, OMS reportaba en los medios sociales que había un clúster, un conglomerado de casos de neumonía sin muertes. Así lo decía en Wuhan, en la provincia de Hubei. Días después, el 22 de enero del 2020, OMS envió una misión a China, ya, de que aparentemente había evidencia de transmisión entre humanos, ¿ya? Pero que se necesitaba más investigación para entender la extensión de este desafío. Y finalmente, el 11 de marzo, fecha que muchos recordamos muy bien, el 11-12 de marzo. Ahí estamos, el 11-12 de marzo. Declaró que OMS declaró que esta enfermedad emergente podía ser caracterizada como una pandemia. Para poner en contexto lo que pasó hace recién 2 años, el tiempo nos parece mucho más longo, pero fue hace muy poco tiempo. ¿Cuál fue el desafío para Brasil y, bueno, comandado por OMS? Fue obtener datos clínicos y analizar la información del COVID-19, una condición clínica que en ese momento estaba poco conocida y caracterizada. Esto ya empezó aquí en Brasil el segundo semestre del 2020. ¿Ya? Junto con ese desafío estuvo el de incorporar instituciones capaces de asumir el desafío tanto clínico como tecnológico de hacer frente a la pesquisa de esta nueva condición, ¿ya? Responder en términos adecuados a los requisitos de OPAS, OMS y también del Ministerio de Salud de Brasil, y contribuir al combate de la pandemia desde Brasil y a nivel global. Esos fueron los principales desafíos. La línea de tiempo que ya José nos coloca que el primer caso sospechado fue el año 2020. Ya en el año en marzo de 2020 ya había una organización aquí en Brasil a través de portería, o sea, a través de una organización formal, ¿ya? Los primeros casos fueron identificados acá en Brasil ya a fines del 2000, de febrero del 2020, ¿ya? Y ya en marzo, los primeros días de marzo del 2020, DataSUS estableció un comité de crisis, ¿ya? Esa es la línea de tiempo general. Y cuando se partió en la iniciativa de COVID de la que estamos en estos días tratando, la primera reunión formal ya fue a mediados, fines del 2020, en que hubo la primera reunión de pactuación de esta iniciativa entre el Ministerio de Salud de Brasil, OMS, OPS y OPAS acá en Brasilia. La primera parte de esta iniciativa se enfocó fundamentalmente al COVID agudo. Estamos pensando que ni siquiera había noción de que podía haber una condición post-COVID cuando esto comenzó. Entonces, si nos ponemos en esta misma línea de tiempo, ¿cuál fue la metodología que se aplicó? Fundamentalmente en base a los requerimientos y al enfoque metodológico, tanto de OPS como de OMS, se inició una pesquisa orientada a capturar datos clínicos en forma retrospectiva de una red hospitalaria. A partir, como decía, de octubre del 2020, la primera reunión técnica entre OPAS y el Ministerio de Salud definió estas condiciones. Se definió un proyecto de pesquisa, ¿ya? Orientado, como decía, a obtención de datos en forma retrospectiva. Todo esto enfocado a una pauta, a una estructura bastante definida por OMS del tipo de datos, la extensión de datos, de la caracterización de datos clínicos que se requería obtener. De eso van a hablar más en detalle los pesquisadores más adelante. Pero lo importante es entender que what kind of data would we would like to send to the citizens? En el ámbito clínico, normalmente no tienen esta extensión de datos. Los sistemas de información propios del área de sistemas de información regulares en los países normalmente tienen datos mucho más agregados, mucho más orientados a la gestión, y los datos clínicos no están tan extendidos en todos los países. El objetivo, por lo tanto, fue capturar datos clínicos de acuerdo a un formato y a una especificación de OMS. Y la forma de hacer eso, dado que el país no cuenta con una extensión tan importante de datos clínicos basado en prontuario electrónico, fue realizar un estudio retrospectivo con ciertas simplificaciones. Y ahí se integró una red hospitalaria que ya voy a mostrar más adelante, que reunía las condiciones, tanto tecnológicas como la capacidad de análisis tecnológicas para poder hacer captura de datos y analítica capaz de hacer análisis de estos datos que diera las condiciones para hacer el levantamiento de información. De manera que durante todo el año 2020, a comienzos del 2021 se hizo captura de datos, y posteriormente ya el año 2021, a finales del 2021 tuvimos un primer reporte basado en la pesquisa de esta investigación.
About the research.
No sé si me pueden pasar la siguiente, porque aquí... Ahí estamos.
Can you go to the next slide, please? Okay.
¿Podemos volver a la de atrás, por favor?
Can you go back to the last one, please?
¿Es posible volver a la anterior, por favor?
Is it possible to go back to the
Falta
last
una
one,
transparencia. Eso, ahí, perfecto. Bueno, yo hablaba anteriormente de la etapa de COVID agudo que se desarrolló fundamentalmente durante el año
in the stage
2021,
of
¿ya? Y
acute
que finalizó con
COVID-19,
la entrega de un
2021,
relatorio y
and
la
that
entrega de
we
datos importantes
delivered a
a la plataforma
report and
global.
important data
Durante el
for the platform.
2022 enfrentamos un
And
requerimiento
throughout
nuevo, que fue el de
2022,
dar
we
respuesta
faced a
también a
new
una condición
challenge
que no se tenía en
that
conocimiento
was a
hasta que fue
response for
desenvolviéndose
a previous condition that
avanzando
we
la
didn't
pandemia,
know
lo que hoy día llamamos
during the
síndrome
pandemic
post-COVID, que ha
that we
afectado de
call
manera
syndrome
diversa
of
y de
post-COVID,
diferentes
that
maneras
affected
a
in
grupos
many
etarios,
ways, in different
diferente en
ways,
los niños, diferente en los
many
adultos, en las
groups,
personas idosas
and it was
también.
different for adults,
Dado
children,
que
elderly people.
esa condición
And this condition
fundamentalmente afecta
affects
a las
fundamentally
semanas y meses posteriores al COVID de una
people
forma que no se
for
conocía a
weeks and
las
months
poblaciones
after
y
COVID, and we
fundamentalmente en el
didn't
momento que
know
ellos son ya
this.
controlados o están fuera
And
de
at the
de
moment
la atención
that
aguda
the
de COVID,
pandemic was
empezamos a trabajar
controlled
primero
and the
intentando capturar una
COVID-19 was controlled, we tried to collect for primary
una
health care
pesquisa acceso a este tipo de
because
pacientes.
these are the
Ahí se
people
hizo
that
una serie
need the
de
primary health
avances con
care.
la
There
atención
was a
primaria.
series of
Finalmente nos dimos
advancements
cuenta de que era
with
necesario
primary health care,
mantener también
and we
una
noticed that it was
unidad de
necessary to
estudio y análisis
maintain
con la misma red
an
hospitalaria con la
unit
que
for
ya estábamos
studies and
trabajando, y
analysis
finalmente la
that
etapa
we
post-COVID
worked
se
with
realizó
before.
fundamentalmente con la red
And for this
hospitalar
phase of the
con la que
COVID-19, for the
trabajamos desde el comienzo. Ahí
post-COVID-19,
están algunos de los hospitales con los que se
and
trabajó,
then
que son
we have on the
básicamente de
screen
la
some
red hospitalar
hospitals that we have been working with.
universitaria de
These are
EBSERH, que es un grupo
the
importante aquí
ones
en Brasil.
that are part of
Agrupa a más
the
de 40
network
hospitales
of
en todo el país,
hospital
hospitales
groups of
universitarios que tienen la
Conceição
capacidad de hacer esta pesquisa.
Health
Ahí
Hospital
tenemos un
Group,
listado
and they were the
del
ones that
Hospital de Nuestra
conducted this
Señora de
research.
Concepción, bueno, hasta otros
We
hospitales de toda la
have
red
many other
de Brasil.
hospitals all over Brazil.
Que hay otro detalle. También hay que decir, trabajamos
Here we
también
have
con
other
hospitales
details
de
and other
administración
hospitals
directa del SUS, ¿ya?
that are
Los
under the
hospitales de la red de
administration
BESER
of
son hospitales
SUS.
que tienen una forma de trabajo
They
conveniada,
work,
con
they have a
una
way of
contratación, un
working,
convenio que muy
hiring
eficiente,
through
operativo con SUS. Pero
consortiums
también trabajamos con
and
hospitales de
groups. They're
administración
very
directa y
efficient,
también con algunas
but also
secretarías municipales
direct
de salud, como fue
contracts,
Florianópolis. Yo destaco
as
esto porque
Florianópolis.
esta forma
I
de
highlight
trabajo
this
fue bastante
because the
flexible
way
y ad
this
hoc
way
al
to
momento en
work
que hubo que
is
establecer
very
la red.
flexible, and
Sin
we
embargo,
had
la misma
to
naturaleza
establish this network.
de la gestión que se hizo
The same
permite hacia
way
el futuro ampliar,
we
modificar,
can
perfeccionar la
expand in the
red hospitalar de
future
acuerdo a los
and
requerimientos de pesquisa
perfect
que
the
se tengan en
requirements
cada
for
momento.
research
Eso es algo que vamos a ver
that we
más
have at the
adelante.
moment, and we're going to see this ahead.
Bueno, aquí solamente para mostrar lo que fue
Well, I
la
just want
etapa
to show you with this
de COVID
slide
agudo, pudimos establecer una red bastante
about the
extendida en
COVID
todo
peak,
Brasil.
and we can see
Prácticamente
this
todos los estados,
healthcare
salvo algunos
assistance
que
all over
están
Brazil
en
with
condiciones de bastante
all the
lejanía
data
en la
that we
zona
gathered,
norte del país,
and some
Paraná,
data
en
were
fin,
more
las zonas
advanced, for
de
example, as
frontera
Roraima
Acre, en fin,
State,
no contaron
about
con
the borders, the
centros desde donde
Amazonas,
pudiéramos obtener datos.
Acre.
Pero
They didn't
la
have
gran mayoría de
centers where we
nosotros
could
sí, como
gather
vemos
this
aquí
data,
en
but
esta
the other
infografía.
states we did, as we can see in this map.
Cuando vemos la etapa de pesquisa post-COVID,
When we talk about
ahí
the
tuvimos un
research post-COVID,
menor alcance geográfico en el
we
país.
had
Y está dado fundamentalmente por la
less
extensión
geographical
que en las
reach
instituciones de pesquisa
because
tiene,
the research
¿cómo
institutions,
decirlo? El componente de atención
they
primaria, de atención
didn't have the
intermedia,
same
también
reach,
especializada intermedia, que permite la captura de
and
datos.
they
De
had
manera
to
que sí tuvimos
they didn't
una
have the
bastante
same reach to
amplia,
capture
digamos,
data and to
cobertura considerando la
specialize.
extensión del país en las regiones que se
And
ven
the
ahí en la
country is also
infografía.
quite large, so it's very difficult.
Ahí está. Bueno, acá solo un listado para mostrar la extensión de este esfuerzo.
So
En lo
here
que
we
fue
have
la
a
estrategia de
list
COVID, al final se pudo contar con
to
60
show what was the
hospitales en todo el
strategy of
país, con
COVID,
60
and we had
instituciones
60
clínicas que
hospitals all over the
levantaron datos
country.
como ya mostraba,
They gathered
en una gran
data,
parte de los estados del país. Y en la estrategia de
and
seguimiento post-COVID casi llegamos a
we can
80
see here
unidades
also the
también de
research for
atención
post-COVID, and we
especializada de seguimiento,
could
atención primaria, algunas
conduct research in 80
en todo el país, de
healthcare
manera tal de que la extensión
facilities and primary healthcare
de la
facilities
cobertura
all over
para
the
capturar
country.
datos
So
fue
the
bastante
extension of
importante a
coverage
nivel del
for
país.
collection of data was very important for the country.
Eso. Bueno, al final cuando vemos los números
When we
completos,
see
el total
the
de,
total numbers
el total de casos que
and
se
the
pudo
total number
capturar
of
llegó casi a los
cases,
80.000
it was
entre
more than
2020 y 2022,
80,000
lo que
in
se ve en el gráfico
2020
de arriba
and up to
a la izquierda.
2022.
Algunos fueron de envío directo a
Some of
OMS,
them
otros a
were
través de lo
sent
que llamamos
directly
el Data
to
Hub, que es
WHO,
digamos la maquinaria tecnológica que permite
and this
agregar
was
un número importante
and
de datos
we have a very important
anonimizados
number of
con
data that were
información muy
analyzed,
completa de
and
acuerdo a
it's a
los
very
requerimientos
complete
que nos
information
estableció OMS y OPS.
that is very important for WHO, the WHO, in
Aquí
my
yo
opinion.
ahora paso a una visión un poco más
Now
desde el área de sistemas y servicios, porque
there
esto
is a
resulta
service
importante desde el
system
punto de
because
vista
it's very
del
important from the
sistema de
point of
servicio.
view.
Bueno, lo principal fue
The most important one was the need for OPAS and for PAHO and WHO to focusing on the timely delivery of data according to the requirements of PAHO and WHO. We had an alliance for research, and we worked together to overcome this challenge, to have this connection with the service systems to work together and collect data. I want to be very frank, and this was very important for Brazil, and after that it was very important to have this sharing of information with the research institutions. It was a very extensive knowledge sharing, and we use tools that are very available, but we reduce the time for that, and we could adapt in times of crisis, and we could perfect this tool that it was existent in other institutions, but it was not applied. And we could maintain during the whole process a coordination for the Ministry of Health and the institutions through PAHO and WHO that have this initiative in a very enthusiastic way. What results we have after more than 2 years? We're going to talk about it throughout the day. So first, there was a formation of a network of clinical research with high-level institutions and a joint partnership with Ministry of Health, Secretariats of Health, and PAHO and WHO. And data was made available for SUS, Brazil, and PAHO WHO. This network is advancing and producing in this moment, and it will continue, and I dare say that it will continue. And also to talk about the clinical conditions for SUS. This is the greatest challenge, I would say. How can we identify the conditions that will make us reflect about what happened and also about the future in a proactive way? Well, as I said, we are in progress. And I like to show you with a that we have a logo. I'm very proud of it. This is a very collaborative initiative that can fight COVID and other disease. This platform contributes with SUS and also with other institutions, and we hope to have more material. And I would like to show you something that I found yesterday and that it's very important to have in mind as well. Let's see if this works. Can you play the video, please? It's from YouTube. I don't know if you can show it. Is it possible? There you go. If you can put it from the beginning, please. Well, it's not working, unfortunately. This is a video that was shown December 2nd. And there is a situation that is happening in China, as everybody knows. So they are undergoing a stressful situation with the population. And given the and there are some new variants that are happening. So I would like just to mention, because it seemed very important to me, because I was navigating the internet and I could see that the COVID variants are very important in this moment. But Dr. Tero said that there are new conditions being established and it is possible to have variants that are more dangerous. So I just like to play this video to show the conditions and the other disease as well, and how we are working with this specific network to gather data about the conditions from the clinical point of view. And also we have to think about that there are very important genomic research, and the clinical research is very important in this case. And I believe that we have a tool that is in use that could give us very substantial support in these situations. I would like just to mention that, and I would like to give the floor to other people in this table.
We'd like to thank Dr. Roberto Tapia Hidalgo for his speech. According to the time, thank you very much. We have 20 minutes for every intervention. We have the presentation of the national panorama, and now we are going to have 20 more minutes to hear the international panorama. We have the privilege to hear Silvia Bertagnolo and Ronaldo Silva. Do we have conditions? Technical team? Perfect. So if can put Silvia Bertagnolo the screen so you can introduce her. Good morning, Dr. Silvia Bertagnolio. Good morning, can you hear us?
I'm gonna now present, I put the slides on. Can you please confirm that you can see the slides? Because we cannot hear anything from remotely.
Temos os slides dela? Ok.
Okay, super. Can you hear me? Can you hear me? Can you confirm that you can hear me?
Yes.
Yes, Silvia, we can hear you.
Can you hear me? Okay, I will move ahead. So please let me know if it's all is good. So my name is Silvia Bertagnoli again, and I am the unit head in the Antimicrobial Resistance Division at WHO in Geneva. And as you well know, the Global Clinical Platform project started in May 2020, with the global effort coordinated by WHO and the regional offices to collect data from individual patients to better understand and characterize COVID-19. And WHO and the regional offices sent to all countries official communication to invite member states to participate to the global clinical platform and share data from individual level patients, anonymized data on the clinical presentation, therapeutics, and clinical, therapeutic intervention of patients that were hospitalized with suspected or confirmed COVID-19. The objective of the clinical platform are all clear. I'm going to go very quickly because you are very familiar with this project, is to characterize regional variation and temporal trends in the clinical phenotype, clinical care, therapeutics, outcomes, reinfections, variants, vaccination in people with suspected or confirmed COVID-19. Number two is understand risk factors associated with mortality, severity, ICU admission globally and by WHO region, as well as by country. Number three is to characterize the clinical phenotype, co-infection, antimicrobial resistance, clinical care and therapeutics, intervention and outcome in subpopulation, for example, children or pregnant women or people living with HIV or people living with TB. And lastly, to describe the mid and long-term sequelae of patients that were discharged from hospital or managed at home for COVID-19. So what we call the post-COVID condition. So the clinical, WHO established standardized case report form, and you can see them in the slides. You're all aware of those. Initially, there was one, what we call core CRF or case report form for adults and children, and there was an additional one for pregnant women. And then later on in the epidemic, we decided to kind of combine the two CRF into one CRF. For simplicity, we have a second CRF, the yellow one, related to multi-system inflammatory syndrome in children and adolescents. And lastly, we have a fourth one, the post-COVID-19 condition, which is meant to collect data on patient discharge from hospital or managed at home to assess COVID-19 sequelae. So for the course CRF, the eligibility, as you all know, is patients that were hospitalized with COVID-19, both adults and children, as well as pregnant women. The course CRF includes 3 modules that has been kind of updated over time to collect, updated to reflect the better understanding of COVID-19 phenotype and then the therapeutics that were used. One module is to be filled at hospital admission, the first 24 hours of hospital admission. A second module is to be filled at time of ICU admission in the first 24 hours. And the third one is to be filled at time of discharge and provide, if you want, an overall summary of what is the patient history during hospital stay. And this should be filled at discharge, as I said, but as well as during, if the patient die in the hospital. And this information include infections, co-infections, co-diagnosis, clinical outcomes, supportive care that was received, and whether the patient was reinfected, and vaccination status. And then lastly, we have a fourth CRF that should be filled for patients that were discharged from hospital with a diagnosis of COVID-19, as well as patients that were treated at home, managed at home for COVID-19. And this was particularly important at the beginning of the epidemic, where many patients did not have access to medical services because of the big burden of COVID-19 and the overcrowded facility settings. So within this CRF, we recommend that patients receive an initial check-in 4 to 8 weeks after hospital discharge or after the acute illness. If during this first assessment we do see that symptoms or signs persist, a follow-up visit is conducted at 3, 6, 9, and 12 months for additional check-in. If symptoms or signs do not persist, then a follow-up visit should be done only at 6 months and at 12 months from check-in. The post-COVID condition include, again, 3 modules. The first module is collecting is building upon the core CRF, and for patients that have already the core CRF filled, there is no need to fill again module 1, but module 1 is relevant for patients that do not have the core CRF already filled, and therefore there is a summary of what has been the situation during the acute episode of COVID-19. Then there is a second module that should be filled during at 4 to 8 weeks from hospital discharge, and there is a kind of a physician kind of visit or nurse visit, and critical information are collected during this visit. And then there is a module 3 that includes clinical examination, laboratory test, and diagnosis of post-COVID conditions and all the syndromes that are associated with that. So how countries, but not only countries and Ministry of Health, but even individual facility or research networks can contribute their data to the global clinical platform. So there are 3 simple steps to contribute anonymized clinical data, and the WHO webpage is very clear. There is a link that can be is accessible to all facilities, and they can register there. They accept a term of use, and then a link is provided, and they can enter the data directly to the platform, or they can simply share the database that they have collected to WHO, and we will be doing some data merging, and we will be able to use and incorporate and pull together the data to the larger data set. So I repeat, so 2 ways of contributing data. One, through just entering the data directly into clinical platform, patient by patient, through the REDCap. The second option is sharing with WHO an already compiled data set, and this then will be used by WHO and pull together the larger data set. And my colleague, Ronaldo, will be able to describe a little bit more in detail what is the lesson learned on that data management aspect. So as you can see in this slide, the many countries that contributed data to the WHO Global Clinical Platform, patients are de-identified, and again, epi data as well as clinical data is shared. In WHO, we do data curation, data aggregation, analysis, and interpretation. This is the second step. And these data are used to generate global, regional, and country reports on clinical characterization. And these data are really, really important for several reasons. Number one, because at the global level, we use them to inform the WHO guidelines on COVID-19 clinical management. Number two, they are used to inform modeling work in terms of best public health approaches in according to the epidemiological scenarios. They also have vaccination strategies, and when the data is shared at the national level, the data can inform the national strategy to respond and characterize COVID-19 in the country. So I'm really proud to show you this updated analysis and information. We, as of November 2022, data from 66 different countries in the world have been shared with WHO. We have over 1 million cases, patients hospitalized with COVID-19. 50% comes from the Afro region, 9% from the AMRO region, 0.5% from the EMRO region, 38% from the Euro region, and CIARO region contributes to 0.1%, and the WIPRO region contribute to 0.9%. The population that we have received include over 27,000 pregnant women, over 55,000 children, and over 37,000 people living with HIV. And these allow us to do specific sub-analysis of the phenotype of COVID-19 in the different subpopulations. So what is the evidence that we have generated from the Global Clinical Platform? As you can see from these slides, we have been doing statistical analysis plan in a very transparent manner for every analysis that we have conducted. And the statistical analysis plan has been uploaded ahead of the analysis on the WHO webpage and are publicly available. We have been using the data to develop and inform a dashboard, which is an online interactive tool for the visualization of platform data. The dashboard is accessible and visible to the public and has been used to show various result, high-level result of the clinical platform data. We have been using, we are in the process of generating regional reports on the COVID-19 clinical characterization and management in the different WHO regions. The platform is not only helpful to understand the clinical phenotype, but also to understand the uptake of specific policy and guidance. So by looking at the WHO recommendation on the different therapeutics that has been recommended for COVID-19, using the platform, we have a sense whether countries have been using and uptaking those recommendations and to what extent the implementation has happened. We also use the data to look at, do an analysis by subpopulation, children and adolescent and COVID-19, pregnant women and COVID-19, HIV and COVID-19, patients with bacterial co-infection and antimicrobial resistance and COVID-19. We have been using the data collected through the platform to better understand the relationship between SARS-CoV-2 variants and severity and mortality. And we have been generating country reports summarizing the situation of COVID in the different countries, generating data. We have generated country report for Brazil, Cameroon, Colombia, Ecuador, Ghana, Jordan, Nigeria, and Zimbabwe. And there are few more country reports that are in preparation. And here are the various country reports that has been published and shared with the Ministry of Health. And I want to also highlight the dashboard that WHO has developed. As you can see in this slide, the different high-level information that are available publicly in terms of treatment uptake, in terms of severity of the patients, gender, age of patient hospitalized with COVID-19, and you can do a search by region, or search by type of outcome you are interested. We also present data on the dashboard on the specific page on COVID-19 and HIV patients, a specific page on COVID-19 and TB patients. And again, you can do a breakdown analysis by WHO region. So you can select, AMRO region and with gender, and you will see result changing according to your selection. We do present data on underlying conditions, as well as present data by vital signs on admission. And, the research can be done again by region, age group, outcome, and data hospitalization, as well as we present data about patient outcome. And again, by region, gender, age group, and outcome, you can screen out and do your tailored analysis. This slide just to highlight briefly the information we summarize on COVID-19 and HIV. And based on we found that this analysis was done in May this year, and we found that people living with HIV infection was an independent risk factor for severe COVID-19 presentation at hospital admission. And people living with HIV were 38% more likely to die in hospital compared to HIV negative individuals. So this information prompted WHO to recommend the prioritization of the vaccination in this population. We also use the global clinical platform data to look at describe the clinical characteristics, severity, and outcome in patients hospitalized with COVID-19 during the Omicron period versus the Delta period. And we found indeed that patients hospitalized during the Omicron period were less likely to die and less likely to be admitted with a severe or critical COVID-19 compared to patients hospitalized during the Delta period. And also we are now actively looking at the antimicrobial resistance, AMR, and in patients hospitalized with COVID-19. As you know, AMR is a silent pandemic, and there is an important overlapping between the COVID-19 and the AMR pandemic. So we wanted to have a better understanding of what are the patterns of antibiotic use across regions, countries, subpopulation, and over time. What is the prevalence of bacteria co-infection and infection by drug-resistant organism? And we wanted to have a sense of whether empiric antibiotic therapy influence clinical outcome. So the updated CRF that is available on the WHO webpage include very relevant variables such as site of infection, bacterial isolation, and type of bacteria, whether bacteria was a multi-drug resistance bacteria, whether a colonization by a multi-drug resistant organism was identified, what type of antibiotic were administered, and when, whether the antibiotics were prescribed as empirical therapy or targeted therapy, antibiotic duration, and fungal co-infection. And what we saw is that these are countries contributing data and providing data on antibiotic use among patients hospitalized with COVID-19. And we can see that the AMRO region contributed with 24% of this data. The most contributors is Colombia, followed by Brazil, Ecuador, and Panama. And what we found overall is that globally, that 80% of patients admitted for COVID-19 receive at least one antibiotic, despite WHO recommendation of not to provide antibiotic, so that administer antibiotic in patients with mild and moderate illness at hospital admission. So this is of course concerning. As you can see, also patients with mild and moderate disease receive antibiotics in over 70% of the cases. Children less than 18 also receive antibiotic in over 65% of the cases. And as you can see, antibiotic was highly prescribed across all age groups. And we also found that antibiotic use was extraordinarily high in the African region, with 97% of patients hospitalized with COVID receiving antibiotic. And the AMRO region was more reasonable, but still very high, with 59% of the patients hospitalized with COVID receiving at least one antibiotic during hospital stay. We also found that among patients that were prescribed antibiotic, basically almost everyone, most of the antibiotic were prescribed in the first 24 hours of hospital admission. You can see in the blue bar is the first 24 hours, and the light blue color means antibiotic prescribed after the first 24 hours of hospital admission. And you can see, for example, in Brazil, that the most of the antibiotic were prescribed in the first 24 hours. For some other countries, this data is even more astonishing. With, for example, in Burkina, as you can see, all antibiotic were prescribed during the first 24 hours. We also saw that empiric antibiotic in patients with no suspected co-infection or no confirmed bacterial co-infection were not associated with an increased mortality. Were not associated with a reduction in mortality, and were not associated with a decrease in hospital stay, underlining the fact that the use of antibiotic therapy is not helping the patient to get better and to die less and to stay less in the hospital. We are now planning to do an analysis on the COVID-19 in the pediatric population and COVID-19 in the pregnant women, and this will come shortly. And I just want to finish my presentation by highlighting that the global clinical platform that started with COVID-19 now is expanded to cover other pathogens. It was launched a while ago, a couple of months ago, to capture information on monkeypox. So anybody that has in any facility where monkeypox is seen are encouraged actually to include data and share data on the clinical platform using RedCap, as well as we use the clinical platform to collect clinical data in patients with severe acute hepatitis of unknown etiology. The Ebola clinical platform was launched a couple of weeks ago, and the Lassa fever global clinical platform also will be launched soon. So these are the global clinical platform for monkeypox, again with the standardized case report form. And this is my last slide, where I really, I want to mention what are the future direction of the global clinical platform. So we believe that has been a very, very helpful tool to collect reliable and standardized clinical data. And we want to expand the use of the global clinical platform to gather clinical data on an expanded set of clinical conditions. For example, patients admitted to hospital with the respiratory syndrome. And regardless of what the pathogen is. And then we will be able then to better understand what is going to be the proportion of patients admitted with that condition, as well as what are the pathogens that are causing that respiratory syndrome. And as well, we would like to also increase in the future the data representativeness, because of course the data that the clinical platform have so far from most countries are not national representative, and the data cannot be generalized of what's happening in the country necessarily, but represent what's the data contribution and the clinic contributing data. So we want to increase data representativeness, and we want to increase the ability to capture and detect changes over time. So we are going to encourage countries more and more to select country level satellite site, sentinel site, that meet predefined site characteristic, and then that commit to regularly collect and share data on a regular fashion. And with that, I would like to conclude and thank you very much for your attention and listening to me, and I'm happy to address any question that you may have. I'm not able to listen necessarily the audio in the room, but maybe in the chat, or I'm very happy to address any question you may have. Thank you so much.
Very good. Now we're going to hear Dr. Ronaldo Silva. So please, Dr. Ronaldo, you can start your presentation. Good morning. I'm waiting for my presentation. So I would like to tell you a little anecdote while we wait. So why am I going to talk about collection and quality and analysis of the data? Why is this important? Because basically we have had some results in the presentation of Dr. Silvia and Roberto, and as the world is also understanding through these results the current situation and where we can get. So we have a responsibility with all of this, with the quality of data especially. And sometimes Sylvia looks at me when she has some results and she asks me, how is this possible? Because there are some results that are very difficult to interpret. So we have to have a certain quality for the data that we have, and then we can verify what led to that result, to that unexpected result. For example, Sylvia has mentioned the comparison between Omicron and Delta. When we did the analysis, considering the data from people that lived with HIV, we saw that the risk with Omicron was extremely high. And when you take a look at this, you ask, how is this possible? And this is possible because the population with a negative HIV has decreased so much that increased the gap between the negative and the positive population. The negative population also had a risk with Omicron, but the gap between them has increased a lot. So this is important. So how can I change the slide? So that is that. Okay, so data elements. I'm talking on behalf of WHO Global Clinical Platform, but I would like to reflect on the work that was conducted by some colleagues that were here. So we have collection, quality, and analysis. And the experience with the data shows me that the three main pillars to have a quality data is the partnership among the regional offices of WHO WHO, and the Ministry of Health and all the other institutions. Of course, this is a simplified way to say because we have all the other organizations as we can see represented here in this meeting. So this is essential because from the WHO side there is a support so the network of hospitals can perform this activity, which is difficult to do this collection of data. This requires resources, not just economical resources, but many times bureaucratic resources. So they have to have the regional ordinances supporting. Ministry of Health taking care of the bureaucratic. Sometimes we have the participation in a direct way. For example, vaccination data and about coronavirus variants. There were some ministries of health that provided this information, and it was possible for the hospitals to register this and connect this to the patient and write the variant for the patient. So we need these three entities working together. And repeating myself, we understand that there are many offices and they're all working together. And then I put here data manager to simplify, but this means the whole team that works with the collection of data. And I personally worked with these people, and this is a direct work. Many times I wrote to the data manager, this is not good. Can you redo it? And they have done that. They got back to the hospitals, they collected again, and I can see some colleagues here. I see some people from Colombia, Ricardo, Gabriela, Rosane. I've also received many criticism. Rosane, I don't know if there's Francis is here. So many colleagues, they would write to me criticizing me, saying that that was not good or we could improve that or have you changed the documents again? So this is a direct communication work, and it's interesting to say that we always ended the meeting smiling, please, because we could improve something about the quality of data. So thank you, colleagues, for the work that you have done, and thanks to you, we could get to this point. On my right side, I put a mixture of concepts, some things that have happened and that were good, and some things that were not good, and some things that we want it to happen. So there's a mixture there. So we're going to identify that. For example, some our experience showed that some hospitals had to review the concept of digitalization of patients because either they didn't have or it was an open field and they had all this information and they had to recover this information and it was very difficult. So this is not an anonymous information to mention a name. I've worked with Gustavo, and Gustavo had this difficulty because he asked, how can I recover all this information? And then he said, we have to improve the quality of data from the hospital, the collection of data. So he could do it, and we have this idea of we have to improve. Another thing is the system, the data system for the health system. It would be better if it was standardized, either by country or by region or something like that, because this will make everything easier. This is difficult, right? I've worked in a research institute in a hospital, so you can have an idea. The departments in the hospital, they do not communicate among themselves. I've worked in infectious disease in Italy, and this department doesn't communicate with the lab results. So it was a sacrifice to recover this data. data link, as I said. The Ministry of Health has to do this to provide enough information. A data hub, I think this is a project of Brazil, where the idea is to manage, to have a centralized management of the data. So this is a good path. Also, something that we have to improve, because we understand that the doctors are overloaded. But we also understand that if they are capable of providing better information with the register of patients, we are able to understand situations like this that we are experiencing now, like the pandemic. And it can be as simple as, let me show you the next slide. Here we have a report, a very detailed one, that we do it by hospital and by patient according to data quality. As you can see, there are 62 data missing, 62 documents missing. I highlighted in yellow 3 points. One is vaccination. So there is no data about vaccination. So what does the doctor have to do? He has to understand why is not the patient not vaccinated, because it was 2020, there was no vaccination, the age rate of the patient was not vaccinated. We have to understand, and we have to believe in the data that we see. The third yellow line is about vital signs and height. This is about the doctor. This is a simple data, easy data to collect. The patients, they tell us their heights, and you register this. And why is this important? We still have some difficulties in the pandemic to analyze the risk factors for obese patients, because we have few data. Patients, doctors, they don't collect simple data as height and weight. So we have to improve this. We have to share this information, and we can do a better work if we do that. I am not complaining. I'm just showing you real situations. This is a challenge. This is a COVID-19 variant. In the first part on the left, we collect the data regarding the variants. And for that, you need the sequencing of the virus. We know that not all hospitals do that and have the capacity to do that, and this is not done with all patients, even if they have the capacity to do it, because it's a more complex resource to manage. But we want to know what is happening, how many variants we have, what is the seriousness of the disease according to the variants. So what we are doing in partnership with the epidemiologic department of WHO, we gather data about prevalence of variants according to the countries. For example, on the left, we can see that there is a 50% prevalence. We know that there's alpha, gamma, mu, delta, and omicron variants for some countries. The other variants, maybe they were present in the country, but either they were not 50%, or the data that we were using was not able to be collected. On the right, for example, we have 90%. When you increase the level of demand for the data, there is an increase in prevalence. So we have gamma, delta, and omicron. So we lost mu, lambda, alpha, that maybe they have reached the level of 75%. So what we are doing now is using this initial data for when the variants were prevalent in the country. We put this in a statistics model, and we can estimate the seriousness and mortality of the disease in that period. Otherwise, what we can do is use the data of the patient check-in in the hospital. And if we don't have information regarding the variant, we can use another alternative. For example, calendar time, every 6 months, what was the situation, like we're doing now. And one of the works that we have conducted was this reported comparing Delta and Omicron for South Africa. So this is something that we have to do it. Colombia has done it for 3 contagion waves to see what happened in the period. And other projects, other post-COVID projects, like Sylvia said. But what is the challenge regarding the data? I heard from friends that it is very difficult to collect this data because you have to follow up with the registration and with the report of the patient. And you know what happens. The patient was at that hospital. Maybe in the second consultation, it changed the hospitals. So we don't have data from the first consultation, from the fourth consultation. So this is a challenge regarding analysis of the data because we're losing this throughout time. So we are together, working together to do a better work. And as it was mentioned, it's not just the platform. The platform has increasing numbers, but also in numbers of infections. For example, Ebola, hepatitis, fever, monkeypox. About Ebola, the objectives would be to describe the clinical characteristics, understand what kind of therapy can be used because this is often experimental, and what is the impact of the therapy used, what is the outcome of the patients, what are the results, and what are the impacts in the patient. We have monkeypox, and we can also describe the cases and understand the alternative therapies used and the after effects of the disease. And to wrap it up, I would like to tell you another story. I was in a pharmacy to buy some masks for my trip, and I was waiting outside because it was a small pharmacy, and I was waiting outside of the pharmacy because we learned during this period that we don't want to be in closed spaces with a lot of people. And a person wanted to get in line in front of me, and I said, I'm waiting. There are a lot of people inside the pharmacy. And he said, oh, but this doesn't make sense. No, but it's common sense. Oh, pandemic is over. COVID is over. And he got in the pharmacy. And we know from the video that the pandemic is not over. We are seeing what is going to happen. And thank you very much. Okay, thank you. We would like to thank you for participating in this panel. Now we're going to conduct the next roundtable. And the moment for discussion, it will happen after the next activity, after the next roundtable. Thank you very much. Now we're going to ask for the people that are composing the table to leave, and also for Dr. Ludovic to remain because he's going to be the mediator for the next roundtable. Now I'm going to announce Roundtable 1, exchange of information between countries participating in the global clinical platform COVID-19 and post-COVID. research results, challenges, and lessons learned. I would like to invite to talk about Colombia, Carlos Moreno. He is the full professor of internal medicine, Faculty of Medicine of National University of Colombia. Welcome, welcome to our table. And to talk about the international experience, I would like to invite to the table Ricardo Zulis. He is the project coordinator in Ecuador, and he comes with Karina Rivadeneira. Please, she is a specialist of the Directorate of Epidemiological Surveillance of the Ministry of Public Health in Ecuador. Please feel free to come to the stage and take your seats. And also to talk about the experience of the network of Federal University hospitals, we invite Eduardo Barbosa Coelho. Please come to the table. Eduardo, he is the Research and Technological Innovation Coordinator. They are sitting at the table. Ludovic Reves, he's the Regional Advisor, Evidence and Intelligence for Action in Health. It will be the mediator of this roundtable, and it will last 1 hour. So, sir, you can have the floor. Thank you. I think that we are a little bit late, and let's go to the presentations, and then we'll have a moment to ask questions. For me, I am very pleased to be at this table. I will present the work with more details, and we'll see how it's important to compile global data, and what we can do with this data is very rich. And we can do a lot of research. We can understand what is going on with the analysis. And let's see indeed what has happened in the countries, and we can discuss at the end how can this experience advance to build a more robust network. So our first presentation is Dr. Alvarez. Thank you.
Good morning. Good morning, especially to the PAHO Brazil. And the presentation from Colombia, I'm going to present the data. And we are here with Dr. Jebe Castellano, the Ministry of Health assessor, and also Elish, that contributes with the presentation that I'm going to show. I'm going to show this work that we have a very supportive team, and we are going to see what we have with this work. I'm going to show the 3-axis data that we work together with the global platform as the other presentation. I want to highlight that this work was possible with the support of PAHO in Colombia and Washington that allowed us in real time we can advance with the work was done beginning at the same time with pandemic. I believe that what was shown, including the pandemic time, was possible to go forward in this proposal. The objective that we had in Colombia was the global goal adjusts to Colombia, and the hospitalized cases. I'm not going to detail that, but it was the same thing that all happened as Dr. Silvia showed. And we worked in models, and what was delayed was the pregnant women. The first model was the adults and the pediatric population. We worked with the systemic respiratory syndrome, what I'm going to show. We have an invitation to different hospitals from the country. I have the points here. The support of the ministry to invite in an equal way several regions, and a limitation that the study had do not represent all the Colombia territory. Was a collaborative work in which the institution share information, then we can make that quicker. It was good, as Fernando showed, to have put every data directly to the platform. And the other way was to concentrate the information and filter the information and allowed that we generate uh, the incomes. So we have a better number of data that was made one by one. That was what we learned during time. The first report was important because we didn't have data how the patients, hospitalized patients, were in Colombia, and the published report was showed in the official diaries to show the information and what was happened with the management of COVID in Colombia, where we have 27,881 patients during an important time. We highlighted some data that how the management was going. These data in the way that was doing was according to the other situations of the other countries to compare, to learn if we are doing good or if you have some difficulties. The initial data shows that in that time and hospitals of the country, we were adjusting to what was happened in other countries. You can see the admission data, the intensive care, and the mortality of 81%, and the overview. We see some data here, but not only the data that we knew, and this with this platform we could understand what we were doing in the management of the hospitalized patients. And we continue to work with more filtered information to evaluate the impact of different variants that are submitted to disclosure, and following and optimizing data that we have from the first part of the study. Then we follow to phase 2, the continuation of the collective of data. We collected the data since the beginning of the pandemic, March 2020 and to July of 2021. And with the different variants, we could collect informations. And then we have to go to have 7,000 data, and now we have 10,000 data. And we hope to compare to mil variants and the other variants. We have some institutions that join in a consortium this data. It's very hard to keep this network because we are going through a moment of transition, along with to finish the pandemic. And the second platform is the post-COVID platform, as said before. We started to work this year in this platform, and currently with the model that were shown, we have the three models and the segment understanding what is happening. We have been having difficulties because another point in which we intend to have information post-COVID is to have that as integrated. So we are doing researches in another Latin American countries in a way that the attention post-COVID has been integrate. That made that to have the information post-COVID is not so easy. We have just a few centers of integrated care if you compare with the size of what is happening in the global scenario. So it was not so easy to have the goal to have between 5 and 10 COVID centers. Beside that, we have improving the numbers. We are over 10,000 pieces of information. And the third, it's a hard issue because we are working with the clinical registration and the children population and respiratory inflammation in this pediatric population, and is very not likely to have the adequate information for the pediatric population, because we believe that in this clinical condition where we have fewer cases, very important hospitals, so we can sum this data in a very important way. So we have been working with this EPCO team, and so we have these frameworks that we all already know by WHO, where the pediatric population show the co-evaluation of this main population, the general population and the neonatal population. We have a methodology that was concentrated in Ministry of Health, and we brought some interesting hospitals to study, and CAP segments did an experiment in 24 months, and we have an important number of pediatric hospitals that was linked to this strategy to have necessary information. We have around 500 cases since last year. We are disclosing this information. And as comments, Sylvia, we also started to participate in the global platform in this moment. We have 165 cases according to the platform. We hope to have information analyzed very soon. We have over 4,000 cases registered, and the advantage of this platform is to have cases that are already analyzed to compare to global data. And the challenge that we have, basically, the process of the administrative processes are being more difficult than expected. In the beginning, we have a good moment that we have the resiliency, and it's a little bit hard to have this communication between its distinctive service, the intensive service of the labs and what's related to big data and the process of investigation institutes, because many times they are not very clear by region. And the most important data that we have that we could include more agile administrative processes, include ethical process, but maintaining the seriousness. And we need to know if it's according to the images that have been showed. We have to have clinical investigation base. Sometimes we do not have the available researchers. And to filter the clinical data, so we can have focal points for clinical and observational study. So we have a difficulty to capture data from lab data, clinical data, that could have a clear and fast information. With that, I end my presentation, and I thank PAHO and WHO, because without the support of these institutions and the Ministry of Health from Colombia, we could not go forward and have the management that we could make effective changes during the pandemic time. Thank you very much. It was a work that was done with Colombia, was exception, almost 40,000 cases in hospitalized patients post-COVID, as presented is a challenge, and very quickly we're going to start the project with monkeypox, and something that we cannot lose, that we can answer very quickly, because we already have the structure is the challenge that we have. And the following presentation, it's the team from Ecuador, Dr. Ricardo and Dr. Carolina. You can start. I think that you can go forward. Thank you very much to you all that are here. Thank you, Ludovic. To us is a big pleasure to present what was the project of the COVID platform in Ecuador. I have my colleague Karina, which is the data minister from health surveillance in public health, and she's going to start with the first part of data. And after that, I'm going to share the experience and the lessons learned. My name is Karina. I'm the representative of the Ministry of Public Health in the Surveillance Secretary. I've been applying this information to our area. I also like to thank the WHO, because without this cooperation, we could not make anything. And here in the beginning of the presentation, you're going to see that. I'm going to talk about the COVID situation in Ecuador according to the 47 epidemiological week. We have over 18 million people, and that's based on the census of 2010. We are in the moment to make the census of 2022. We have over 1 million registrations identified in our system, with people that passed away and died from this disease. Currently, we have the 0.9 lethality, is less than 1%, with 30% of RT-PCR. We have a problem with samples because we have limited resources. At the left, you can see the epidemiological curve based and different datas due to the lack of the system. So that's why you can see and here in 2022 you can see the access from what we have 2021 2022. In the right you can see the incidence tax in Ecuador, the main where we find the main disease that we have in Ecuador, where we find that are per regions. On the left, we are facing the lethality versus the COVID cases. You can see a peak, but it's less than 1% in all of these weeks. We have the Phoenix plan that the government implement, and we have as a pillar the vaccination. And we have close to 40 million doses in the complete scheme that have 2 complete doses, 1 boost. We have 4 phases. In each one, we have the impact on the gravity of the indicators. Currently, we have 80% of people, 50% of the people that were vaccinated with the boost vaccine. And our system, we have a system that is shared. We have the private and the public sector. The public part is where we have the public Ministry of Health and the Social Security and police, and have the private system where we have over 39 doctors. It's not separate by area, but this is the overview. And we have Covid-19, which were over 1,000 beds. And from these descriptions that we have in our country and the necessity that the data of incidence and lethality do not allow us to see a description of the clinical characteristics that we could have from COVID on the hospitalized patients. So we decided, along with PAHO, to the inputs on this WHO platform to reach the goals and describe the clinical characteristics of the COVID in the country and identify the association of the characteristics with the results, and also describe the time tendencies of the of COVID. To that, as the first part of the implementation methodology, the ministry is the authority in the country, so everything that is in these organizations, it's what is from the authority. So along with PAHO, we had the opportunity to put clinical data of COVID inside this platform. To put that in the context, Ecuador during the pandemic of COVID made something that we know as the sentinel hospitals that are reference centers from to COVID. With that, we could identify more easily the the relevant things of the patients in the hospitals that we work with. For example, the Espejo, the hospital that is the biggest hospital in Ecuador. We had Pablo Arturo Soares Hospital, Henrique Garces Hospital, Vicente Corral Moscoso, and Baca Cortez, which is the one that responsible for the ethics in our country. So with that, we could identify three main points in the data. We have the identificative data. From that, we could identify the patients and their characteristics, and the ones that were related to the clinical historic, what allowed us to extract the data and manage the data, and also data that we could not have from the clinical report, but we have to digitalize that. To do that, we have several phases to implement this methodology. The first one is the preparation. I would like to thank the support that we have from Colombia team, because in the beginning we were so lost what we should do in the platform. I would like to thank the international team from WHO and Colombia team that help us. And beyond that, we start to have the variants issue, so we can adapt the databases, and overall the training to recognize the data. So those were the 4 stages that we have. With that, we could fill the reports to the core of COVID, to the pregnant women and the co-infections. The first phase of implementation in the methodologies inside the hospital, we started with the awareness of the data, implant on the system, to digitalize, and the validation of the segments. And beyond that, we have 14 visits inside in the hospital that we were with the work team and with a meeting to gather the data. And with that, we have a very good improvement, that the CRF was unified, and that turns to a problem to us, so we could implement integration of the systems. And at the end, with the WHO support, we could do that. Our percentage of digitalization was very low, and one of the goals that we have from that was to centralize and obtain over 1,000 cases, and with pregnant women 168, and the possibility to have clinical data to the inflammatory mood system disease. Until April of 2021, we made all the extraction of clinical variants, and we realized that we need to put more data that were important to field a better sample. So we changed the methodology, but we optimized the digitalization of the inputs of data, and where the digitalization could be lower. So we decrease the risks and mistakes that we could have. So we decide to go to Paulo Arturo Soares Hospital, with a Sentinel hospital, in which our information system was very easy and identify easier. So we have data that was in this sample, and from 2022, post-COVID, with this using this system, we could have improvements of the digitalization in Espejo and Pablo Arturo Soares hospitals. And then we had important data that we could not put in the platform. But we had over 4,000 cases identified, which is very important expression from what we did in the second and third model. We are going to present the human resource that we had, and I was in charge in the PAHO project. We have the national focal point. That was very good to have the possibility to enter in the hospitals. We have a lot of experts in database that was put in the hospitals, and people that were made in this typing. This was the people that were helping us in the methodological process. As a result, we have 4,584 participants registers, and over 4,000 entered to the analysis, helped us with the report to WHO. And we have over 4,000 participants analyzed for the final report until 2022. And in the important data that we have to highlight that we are in the social demographics variance, in which all the countries already follow. And I want to make clear that a higher percentage of the numbers that we got was in the people that were in the 45 years old, was the worst, the most exposed people. We have a data here that call our attention, which is the amount of the security that we have inside, the percentage of the participants inside the hospitals. That was important to understand that in the Sentinel hospitals, the patients that have severe hospitalization, that one of the reasons that we don't have a demography larger in the case that were used in the data. In the symptoms result, we can highlight that we present the same congruence in the level of the chemical evidences and the data in the clinical investigation to the mild and moderate patients, and the proportion of this one, and also the mortality results. When we have over 35% of people with obesity and 1% of and inside the management, it's important to see that many patients that receive management therapy and the activity and the majority of them received medicine orally. And another thing that we have to highlight, the experience that exists and something that was very important to show in our data. And we need to understand that in the oxygenotherapy, we have closely 93% of improvements of the severity index that we had in the hospital. These data were from the Sentinels Hospital. We have almost 28% of VMI and 20.8% of VMNI. So non-complication results, the ones that are most important, was the respiratory diseases and enemy, and the ones that were identified in the therapy. So we have to see that time of what was happened during the 11 days. We have a text index of 6%, and all this data that is shown in the slide, like discharge. And finally, we have a lethality that were from 12.7%. A lethality rate of 21.8% and UCI of 44.1%. And the age group of the elderly, in which in men we have the higher lethality identified. As a final analysis, what we have from this initiative, one of them was the fragmented health system, which offered the health providers, because we focus on the public hospitals and providers on the level, and the public hospital were the one that offered the data according to the variants that we have, and the data of Sentinel hospitals compared to and the centralization in the Sentinel hospitals. We have all the people concentrated in one hospital, and the team was dedicated to this project. Committed teams working on that, so that allowed us to hire multidisciplinary work groups. We have focus points in every capital, the consultants for every project, and through power query and homogeneity of the data. Finally, we have to highlight some lessons learned that we have in the Ecuador project and the level of international cooperation. It was fundamental to us, and the support of Colombia that allow us to open the clinical platform to the main core. And what we have in the clinical project to identify the quality of the data inside it, and the methodology learn, because we have a very big heterogeneity, and the possibility of the recollection of data. We have to thank the WHO that make easy to identify more participants inside this initiative and strengthen the radio feed from OPAS and WHO that helped us. And I would like to thank Ronaldo overall because he was a fundamental person in this process. To conclude, we had an integrated surveillance system to the epidemiological disease, but we have to take care of the gaps of data because this project help us to do the demographic profile. And we had this process inside the platform. And that allow us to have the information management inside the ministry. And another conclusion is to identify the continuous improvements in the country level and allowed to generate international cooperation between WHO and the regulatory agency in the public and private level. And it's a resource of information that's important for the agencies and the institutions. Thank you very much.
Thank you to the team of Ecuador for this detailed analysis of the challenges and steps that exist, and they are very important. Now we're going to the last part of the panel. It will have a talk of Dr. Barbosa. Please, Dr. Barbosa. Good morning, everyone. I would like to present the experience from EBSER and also to contribute to the global platform for COVID-19 data. Let me see if I can work this out. I wanted to bring a little bit about how EBSER contributed to the project and showing what EBSER is and how does it work, because many of you may not know what is EBSER. It is a company linked to the Ministry of Education, and the role of EBSER has as a focus to manage federal university hospitals. We support and manage 41 hospitals that are linked to 23 universities in Brazil. The healthcare for EBSER has an important characteristic. 100% of our institutions belong to SUS. They are public, and basically they work with medium to high complexity at SUS. They are university hospitals, so they have a very solid role to graduates and undergraduates, and also in the research area. So you can have an idea. We can take a look at the map at the EBSER network. It is present in most of the geographic units in Brazil, except, as you can see, Acre, Rondônia, and Roraima states. Basically, these 3 states do not have EBSER units, but in all other municipalities and states we have EBSER. And this is very important from the strategical point of view for research, because there is an important characteristic. We have a medium and high complexity treatment, a high quality treatment, and we can understand the problems, the health problems in the country as a whole. This is very important for EBSER. I'm sorry. Okay, thank you. So we have a research management system. Part of these represented in this picture are researches in the international level. I showed you this so you can have an idea of the projects. And we have registered more than 4,000 projects of research within the network, most of them of academic formation. So for scientific initiation, for graduates and undergraduates. And I would like to highlight that within the theme COVID-19, EBSER has contributed in a very important way for international and national institutes. And here we can see the number of projects that we had in our registration, in our system. So this year we've had 320 projects that are happening in our hospitals. I brought as a highlight for the international participation how much the network was relevant to develop vaccines. This started in 2020, and we have all the vaccines that are available in the vaccination program except for Pfizer, because Pfizer's strategy was to develop research in private centers. So I brought here a slide so you can have an idea of the contribution of EBSER network throughout the time. This shows the number of beds that were available in the EBSER network throughout time. And you can see that these numbers, it was variable. And the number reached in 2021, 1,000 beds available for COVID-19. On the right side, we have the 10 most important hospitals. Paraná and Uberlândia are the ones that are more highlighted as hospitals that really contributed and participated in the COVID-19 pandemic. To compare what happened within the network and what happened in Brazil regarding the pandemic, EBSER registered more than 40,000 cases up to February of this year. So this was a very important number of cases, and as you can see, the lethality was shown. It was variable throughout time according to the variants and the vaccination. They were responsible for that. And we have seen a lethality of 2% in Brazil, and in EBSER 13%, reflecting part of the medium high complexity. So patients that were in ICU beds where the mortality and lethality was higher. And also we have observed number of cases by university hospitals. The most emblematic one is Paraná, with more than 200 cases, as we can see. And we have seen a distribution that was very important in all the states in a general way. When there was the invitation to EBSER to participate in this international platform, I was starting my work here. Giuseppe was the head of this project. He's our director. And Giuseppe called me for a first meeting, and he said that the challenge was how can we obtain data from these hospitals and how can we contribute to the platform. And EBSER had a strategy to have a single registration, electronic registration for all the hospitals, but this strategy was done late. So the process was in progress. And in the middle of the way, the pandemic started. To implement this electronic system is a very difficult task. There is a need to trainment. So the maturity, the digital maturity is very different in all the levels. So this has impacted a little bit our data collection. So EBSER has a single system to capture data, and it's being dynamically implemented throughout time. I'm not going to repeat this slide because we have discussed the objective of this platform. But historically, we started from an initiative that was very curious. We didn't have people in the human resources that understand exactly about data science and research in the WebSphere network. So we had more administrative people. And thanks to the initiative from PAHO, we could allocate for this project collaborators that had a context of understanding data science, Rafael, for example, and Leonardo, that was one of the creators of this network. So both of them were fundamental so we could establish strategies for data research. Different from other colleagues that have manifested here, we're not working in the university hospitals. We're working at the administration, taking a look at data. We don't have access to the patients' reports. So this was a challenge for us to manage so much data. There were more than 10 million reports that were processed, and how could we extract this information? So we hired some collaborators with the support from PAHO, and with them there was a teacher from the nursery program, and she was key to do the translation between the digital and IT world, and also the health data world. And without them, we certainly could not do anything in this project. And from there, we had the first version of the project, and we imagined to fulfill the CRF and contribute with data. Ronaldo knows that it was very difficult for us in this first moment because most of our data had a lot of blank information. And we noticed that most of this was because in the GHU there are few structure fields, so it was important to have a strategy. So this was the first learning that we had, where we required to have a strategy to extract non-structured data. As you know, this is not simple. Ronaldo manifested this, and we had this obstacle in the first moment. So there were a lot of data that were lost. Our strategy was based in identifying the data, the COVID identified by SID, and we knew that we couldn't find all this data among the volume of data that we had, and this was difficult to capture data throughout time. This is something that's still present post-COVID. The third problem was that they are not updated real time. So we can't to extract those data, it demanded a lot of time, a lot of cost, and basically it didn't work, and we had to do it again because the database is not dynamic. So this was a problem for us, and it continues to be a challenge. So in this first stage, I think that this was one of the first lessons that we have understood that we had to develop and improve. And then Rafael and Leonardo, they have a company, they work with health data, and they were developing a strategy to capture non-structured data, to transform that into structured data, and they transformed it into Smart Health Connect. And this system allowed us to have this strategy. Of course, this was an immature system and it was not trained for COVID. You know that artificial intelligence needs to be trained so it can learn the model, what kind of data we are extracting. And from our first meetings here in Brazil, we understood that we were at a historical moment where we had to document these efforts and get this data from COVID and registered at the data hub. And this was supported by Ricardo at HCPA and Fernando from the Conceição Hospital Group. So this was a moment that defined the success of this project, because from that collaboration, there was the possibility from HC in Porto Alegre, where they had the physical reports, to train the internet artificial intelligence, and also from Gabriel that understood a lot about science and data science, and we could capture this and we could improve the quality of data. So this was very important to improve the quality of data. And from then, we had the initiative to have this data hub in Brazil. I'm not going to detail this even more because we're going to have presentation about it. And we have the idea to have a gathering of data, a collection of data, that we could have other research projects on this database, and we can understand many aspects of the pandemic: cost, epidemiological data, comorbidities. I think this will be a very important contribution, and this will be a legacy for the project with the support of WHO. And I brought some data for you. So you can observe we have improved the system a lot. So out of those 40,000 cases, we could extract 23,000. And this is very important because some hospitals are very immature regarding data collection. Some of them still work with paper. And two regions in Brazil, we could contribute a lot. Basically, Midwest and Southeast. This was very significant. Sorry, Midwest and Northeast. So you can have an idea that the extraction of data, it was made in a very important way. We couldn't get all the 41,000 cases of 41 hospitals, but we had very rich data, and it could take the opportunity to use this for the platform. One of the characteristics that is very interesting, I brought this picture for you. For medium and high complexity, these were patients with comorbidities. So this justifies a lot for why the rate of lethality of patients was high for this. And there is a curiosity. How was the rate of checking in for some data? So we could see a delay about having some patients committed to the hospital. And we have mechanisms to understand about the dynamic of the supply of beds throughout the time. And I think this is a very interesting model to be explored in the future in Data Hub. So to wrap up about post-COVID, this was the last CRF that we were invited to contribute to. And since the first moment, I talked to Rosane and said that it was very difficult for many reasons, but the main one is to define post-COVID. This is very difficult. It's a very complex syndrome, especially talking about treating patients that have a lot of comorbidities, a lot of disease in the hospital: cardiac disease, respiratory disease, what is COVID and what is not COVID. So it's very difficult to separate things in post-COVID. This is a great challenge, we know. There are no defined protocols for post-COVID. This is a gap. Each hospital follows its own line of care. We are following up on patients that were previously committed, but we have many patients that were not from the network, and they were referenced to these units, to these healthcare units. And basically, what we see, the contribution of EBSER is in the services of pneumology, neurology, and rehabilitation, because there are a lot of our patients that have participated in the rehabilitation post-COVID. Another point is that most of our patients are complex patients. So to take a look at these patients carries a bias. So these are very sick patients, very complicated patients. In terms of representativeness, we have the numbers of HUFs, healthcare units. They answer the question, do you follow up on patients who have COVID? Yes or no? And many people said that this service is distributed through Southeast, with Minas Gerais being the great representative, with 4 hospitals, and also the Northeast region. Again, EBSER has this interesting characteristic to have a national representativeness, and I think this is our contribution. I'm going to conclude with this last slide, basically just to show you what is EBSER and what was our contribution. But there are some points that are very important. The use of IA technicians allowed us the extraction, deep learning. There are a series of elements of artificial intelligence that are connected, but it has to be trained. And to answer the question about the trainment of COVID, capacitation of for COVID, we have to practice, we have to train. This is a great challenge, and this limits our strategy. The elaboration of dynamic strategies, it's very important. We know that the data have a 1 day delay, so every day we have new data, but we do an extraction in a single moment. To establish this strategy, to have this dynamic strategy, this dynamic updating is key. And finally, we have all these challenges to extract medical reports. You know, you have experience with that. So this is very heterogeneous and many times incomplete. So to get this data from patients' reports is not a simple task, but the experience, and Gabriel must talk to you about that, about the projects that we developed with COVID. This was very exciting for us because the accuracy of the data was very high, and it surprised us from the point of view of quality of data. So this has posed future challenges to use not only for COVID but for other disease. We imagine this is a very important progress for this project, and I want to count on your contribution, and OPAS and also WHO. Thank you very much.
Thank you very much, Eduardo. We're going to have a very brief presentation with discussion now. If you have any questions, I don't know if you have any considerations to do, you can reach any microphone. If you don't have any question, Colombia can start, or any other people. Dr. Castellano from Ministry of Health, if you have any particular comment, you can. Brazil can comment too. And PAHO colleagues that had the leadership to organize the coordinate groups. And I believe that the experience, if you can share very briefly, we do not have many time, but Dr. Castellano, please. Thank you. In the minister matter, it's a very relevant activity. The ministry participate in a very significant way. We have an integration, the point of view of PAHO and the global guidelines from PAHO. So we have a lot of benefits. One of the biggest challenge that we have with the public hospital and as in the Brazil's experience, is the biggest difficulty. So we have some characteristics in the collection of data that's very specific to the investigators, which are linked to the public hospitals, that it's a big challenge around, and there is a large amount of information with an ad with an effort from the civil society and a combined effort with the scientific society that defined protocols and the guidelines of the clinical reports. That's very important and allowed in a very quick way that all these elements and leaderships that we did in the real time will affect in a very quick way the proposals of clinical management and the clinical cares that were a dynamic to the civil society, the ones that participate with a very high effort, that we had this information as base and very quickly could be modified and follow the rhythm of the information in real time. So we have some challenge around the public healthcare, where I believe that is one of the pillars of the system, which in your case, I don't know if you consider in this way, it was a source, a permanent source of conflict, but without a very big, because the health system in Colombia is very crowded, and we have a conflict between the private public part, and we have to consider that in the make decision. And the strength of surveillance in the country to confirm the infection generate a big amount of data about the confirmations in the end as the result of the cases. So we have several elements since the view of the Ministry of Health, the effort of the health system, and the resource that allowed us to move in a very quick way to allowed us to have a multidisciplinary team and also favor the activity to have results that are very robust, decent, and the possibility to use these resources to implant this work initiative in clinical platforms. In the Colombo case, the surveillance system of microbiological system. We have this work been doing in the last few years. It's a little bit delayed, but it was the drive to have COVID. And that it's a very important factor to use this platform and our approach to the diseases, chronic diseases. that are not infectious and another conditions that could be benefit with these conditions. Thank you very much. I don't know if anyone else want to talk, or would you like to say something? Just a little thing. In fact, the this is so hetero to create the mechanism of information, but fight and have the rules to. I think that's something good, but I learned in the process, and I believed to leave a database of knowledge to use in the future project. So you can use to any other diseases and infection disease in all institutions. Thank you very much to Brazil colleagues. Would you like to say something from Brazil? I'm Ivo. I'm from Brazil. I represent the Children's Hospital from Brasilia. And I would like to know from Colombia that we have a positive rate in pediatrics very similar to us. And I would like to know what was the lethality rate on pediatric and side that we have any comorbidity in the pediatric patients. We are in the analysis phase of the information to send this rate as an overview. What happens? It's that we have a register risk related to the one that was attended in the higher level of complexity, but what we have from information is what was the management result in the intensive care and the management almost 500 children. Perfect. Do you have any other comments or questions? Gabriela, do you want to make any comments? I would like to mention that the leadership of health authorities in Ecuador was fundamental for us to join these initiatives. And as Karina said, the looks that this administration has is very clear to guide the country to contribute in this kind of project. And the other thing that I would like to highlight that is important, the dynamism that we lead with, that we treat the information. That's important to assure the trustworthy of this project. One of these projects has the opportunity to keep working and put the focus in what was not done yet. We are sometimes very busy to have this emergency information and to link the cases and process, and now we have the maintenance focus and the data related to the clinical reports. And the other thing that I would like to highlight, that was a great opportunity to detect and to improve in how the countries are dealing with information. And this identification of opportunities was from the micro, as how the teams worked in the hospitals, and they saw that there weren't any register. Something simple, but it's an improvement opportunity in the micro and micro level. We can see things that we could improve in the systems, and we can integrate as a country, as we saw with the scope kind of cooperation that are developing. For example, in Ecuador, we are going to work in training of integration. Thank you very much. Would you like Monica to add something? Monica was here in Brazil and now is in Colombia. Roberto is still supporting in a very solid way. It's just a matter of time. I had the luck to join Brazil and Colombia. Follow this process. I think that was one of the intervention with a higher possibility to understand what happened with the patients and to characterize the work and support in this way. I would like to congratulate Brazil's group that growth a lot and Colombia team that received and accept, and I said that we are very interested to see this project. And one thing that was important here in Brazil was the participation of the Ministry of Health team that has a systemic financing here in Brazil too, as a part of the politics, and also we want to committed to keep contributing with the information, because I saw that the synergy was very important in this process, and we have a global circuit which is very good that give us trust to follow up. Thank you very much. I do not know if anyone would like to comment anything else. I would like to thank for this moment. We are in this last 2 years with this project and have so many shared experience. It's a enrichment process of our researchers that have been contributing in this project. I would like to thank Parro and Dr. Ludovic and WHO to give us the opportunity to be together contributing with the global platform, but also in your country facing this adversity that we have been seeing through these last 2 years. And now with this project related to the post-COVID, as everyone said, the challenge, the enrichment, but at the same time the difficulty to collect and analyze, and mainly to identify in a clear way related to what is post-COVID. All of us are going to have the opportunity to know the enrichment and the experience. And I would like to thank Dr. Roberto that trust in us, and Dr. Monica since the beginning trust in this project and gave us this great opportunity to thank the delegations from Colombia, Ecuador, to share with us these experiences. I know that we are ahead of time, but fortunately, and at the same time, unfortunately, we have the match at 4 p.m. And as soon as Dr. Ludovic conclude, we are going to have lunch at 1 p.m. But we are going to begin with Dr. Renato Tasca in this next panel. So we reprogram part of what we had today, the fourth table is going to go to tomorrow, and we have this event to 1 a.m. So we're going to have an effort. I know that we are all tired, but to have the opportunity to everyone present their experience and sharing with CONAS and CONASEM. Thank you very much, Dr. Ludovic. Thank you very much to all the participants. So to conclude, we are going to remind that CVC has over 1 million of data and cases, and a good part of Africa and Europe, and obviously the curiosity of the nature of Africa is that the systems that are in South Africa that have collected a good part of this data. Even in Europe, we have an institutionalization of data that came from the ministry data and allowed to input this data in the system. Can we do the same? Of course, we have a potential to do that. The project that we did in every country, what we did are vital, and I think that we need to keep doing that. We have to have some rest. We are going to wait 10 minutes and we are going to get into the details of the project. A final comment of 30 seconds. I think, as Mariana said, we have to have less boutique studies, residual studies, and have more cooperative studies to have data that change everything, to study not only a hospital or just a state, but contribute in a global way. Thank you very much. Would like to thank for this first roundtable. Now we have 10-minute break, and we are going to come back to the second table. Thank you very much.
Please, let's continue the activities of Roundtable 2 as is in the schedule. The use of artificial intelligence and other tools for the integration of SUS information systems, challenges, and lessons learned to generate knowledge about COVID-19 and post-COVID-19. So I would like to invite to the stage to coordinate the activities of Roundtable 2, Mr. Renato Tasca. Renato is Associate Researcher and Public Policy Consultant at the Institute for Health Policy Studies, and it will be the moderator and coordinator of this Roundtable 2. I also like to invite to the table Ricardo Kuchenbecker. I hope I pronounce it right, Kuchenbecker. Thank you. He is the Management of Risk and Professor of the Federal University of Rio Grande do Sul. I would also like to invite to the table Gabriel Miller. Please, Gabriel, he is a student PPG of the University of Rio Grande do Sul. He is also a professor from Vale do Taquari University. Welcome. I would also like to invite to be at this table Nésio Fernandes de Medeiros Júnior, please. He is the president of the National Council of Health Secretariats, CONAS. Please come to the table. And also Gabriela Nunes Neves. She is the substitute coordinator of the General Coordination of Innovation and Informatics in Health. Welcome you all. Sandro Tiarabi, he is replacing Nésio Fernandes de Medeiros Júnior. Sandro, can you please go back to the stage? Perfect, thank you. Well, welcome. Please take your seats. Mr. Moderator, to conduct the activities, you have the floor. Well, good afternoon. Good afternoon, everyone. Possibly this roundtable, well, welcome first. Welcome again to our guests. Possibly this roundtable will be split in two parts because we have 4 presentations and we're not going to be able to do this before 1 o'clock. So let's start with the presentations from the Ministry of Health. Well, I'm going to make a comment, and the time was 20 minutes. Because of the delay and the game and the South Korea. So I'm going to ask kindly to the rapporteurs that they maintain 15 minutes for their talks. So I would like to start with ladies first. I'm going to start with Dr. Gabriela Nunes Neves. She is the substitute coordinator of the General Coordination of Innovation and Informatics in Health from the Ministry of Health from DataSUS. She is going to present to us the experience of the Ministry of Health of DataSUS in the integration of the systems in the US and the SUS and the challenges of using artificial intelligence to generate knowledge. It's in the program, and this roundtable is about this topic: the use of artificial intelligence, what was possible to use, how this tool was used during the pandemic, and what kind of perspectives for the future can we use. Everybody's very hopeful towards this tool, and everybody thinks that artificial intelligence will work and we will not, but this is completely the opposite. And now I want to give the floor to Mrs. Gabriela. Can you play my presentation, please? So, good afternoon, everyone. Well, as my time now got smaller, I would like to thank first for OPAS to share my experiences and share the experiences of DataSUS. I would like to greet the table. I hope that we have a rich discussion. As it was presented by the coordinator, Renato Taz, I am a substitute coordinator of the department, and I am a manager of the app Conecta SUS, of the Conecta SUS program. So I'm going to bring here the integration perspectives and the challenges of the use of artificial intelligence. So here, to give you a little bit of context, I will bring to you the National Politics for Information and Informatics in Health. It is a historical conquer of the Council during the National Conferences of Health since the creation of SUS to be a policy that treats about health data, about collection of data, and about dissemination of data. In 2020, DataSUS reviewed this policy, and during 2020, it was published in 2021. A public hearing was made to update the concepts for information and communication in health. And what are the main updates for this policy that we call PINIS? It recognizes the national data as an integration platform for health data, and it has an interoperability. It's more than integration, is to operate among systems, and the difference among them is time. So now we can talk about a timely manner to get these data as soon as possible in even real time. Here at PNIS, we want to enhance the technology, and we have brought authenticity, traceability, and quality of data about the personal data with the from the law 13709, and we want to evaluate for the solutions and for the health for the digital health solutions. And I would like to highlight the committee management of digital health and the National Council of Health that follows the activities and monitors the digital health. Aligned to PNIS, we have the national strategy, digital health strategy for Brazil, that we see in the horizon of 8 years strategy actions for digital health. So aligned to PNIS is to continue the care, access to health, to qualify care and flow of information, strengthening the support to clinical decisions, surveillance in health, regulation, management, research, and learning. The strategy brings 7 priorities that are guidelines of PNIS, and it shows a strategic view that is also aligned to this national data with this platform for all the country. I highlight here 2 priorities. The 6th one, the environment of interconnectivity, which is the network potentializing the collaborative work among all the health sectors and also technology. to bring digital solutions, patterns, models of services, policies, and regulations so they can be put into practice to strengthen this environment and that we can ensure a collaborative model, a cooperative model that was mentioned in the previous roundtables, and also the ecosystem of innovation. When we have this environment, this collaborative work, we can take the advantage to have this innovation, to have this innovation lab subject to guidelines, to policies, but we can be a booster to have new solutions, digital solutions, and offer to the whole country in terms of health. And what is RNDS? We say that RNDS is not an information systems anymore. Today, we say that the Ministry of Health has more than 600 systems of health. We say that there is a Kabbalistic number. And in Brazil, we have more than 2,000 types of health systems about operation, collecting data. And RNDS is not just another one. It is a mechanism to connect any information system. We say that today each system has its own language, its own purpose, and we want to make sure that they communicate among themselves, that they obey a certain pattern, and that we can have exchange of data, exchange of information in health. So this is the objective of our RNDS, to connect these different players, different systems, and establish as an interoperability platform. How is the process? In a very objective way. So we define about the governance of the management system. We create a GT, a working group, and we define the variables. What is the minimal set of data to exchange information? So it's not exchange everything that is in the system, in the electronic report, but what are the most important variables to exchange information? This model is a pact between the three federal agents, the government, state, and municipalities, and is published in the official gazette of the government. So we can say what is the minimal set of information to exchange this information. Then we elaborate a computational model, and then a pattern is established, and RNDS has adopted a FIRE pattern. We model this information and we capture the different information from the different systems, and we direct them to connect SUS citizen, connect SUS professional, connect SUS manager in the future. But the idea is to have this database of health information and to exchange data in real time. Here is a little bit of the architecture and the structure. Here I wanted to highlight the more negotiable level. We see an analytics. All the information that are received by RNDS, it goes to a database, and from there we can conduct research, we can have artificial intelligence. The use of the information that are in the RNDS are endless. Today, about numbers, we have more than 225 third-party systems. When I say third parties, they are systems that are developed in the ministry itself, or bought or developed in the state or municipality. So we have more than 486 million vaccine doses in the FIRE pattern. Not just an interoperability pattern, but also semantic interoperability about terminologies to exchange health data. We have more than 618 labs that are qualified and are exchanging data with the system and are feeding other systems as well. So we receive data from private labs that feed the Notifica, which is the system about the COVID cases and the vaccines. So this is a flow of data that is already structured and more than that, interoperable. And we have more than 60 million results in ConnectaSUS. Also, we have more than 2,500 basic primary healthcare units. Here, these are the three platforms. ConnectSUS Citizenship, which has the app. So in the palm of your hand, the citizen can have this information. ConnectSUS, we have the professional, and ConnectSUS manager. In the future, they will have access to this data and also indicators. Here, I wanted to highlight the vaccination certificate for COVID. We were one of the first countries that were able to issue that, and it follows the standards of the European Union. From the fire pattern, we did some mapping and we can read the QR code. And my time's up. Also in the countries that share the public key of signature of the certificate, and they can also read our certificate issued here. And at last, we want to present commitment data. We have this already published, but we have to model this in the computer, but we already have some data from the system of the hospitals and also from the files of the committed patients. So we can disseminate for the citizen, for the professional, and for the manager. Here, very quickly, we have the ConnectSUS Citizen. We have more than 36 million downloads of the app with an evaluation of 4.6. And we dare say that this is the largest app of health app in the world. And we want to increase this number, and not just of downloads, but of active users. And you see that the increase of downloads was as of the presentation of the data for COVID and also for AI. I would like you to reflect about this. We don't use these data for this yet, but we understand that artificial intelligence supports the decision making, and it's not the only tool for that. Of course, the quality of data that feeds this tool and any tool, it's important to have the quality of data. As we have invested so that this can be done in a right way and that we can make any kind of sanitization of this data so we can use the best way possible. The algorithm have to be transparent and avoid biases in the decision making. Ethics and human rights is in the center of our concerns that who has brought for digital health area. Also incidents of the information of for information security. Also the necessity for regulation and definition of limits and rules in the use of IA. For technology, there are no limits. The only limit is ethics, and we need, besides that, we also need some legal regulations. I'm sorry. And there are some huge gaps about health data. So we may need to have a very specific norm to talk about this. Do I have one more minute? So this is the video of ConnectSUS. I just want to market this a little bit. So this is just there is a song. for this data information.
With health information, we bring health articles from A to Z, personal information, the locals, the certifications. We can emit COVID in the app, which has a web version and could have it available. A lot of actors, because the app could be a tool to insert data in health. And with this size of download and active users, is a tool in potential to use AI to train machines to learn a little bit about the Brazilian health. We need to do the regulation and see the best way to make that this data available. Thank you. Thank you very much, Gabriela, to sacrifice your time. So after a debate, we can see if can get it back. Now I'll give the floor to Sandro, which is covering this speech. Nezio, it's the president of CONAIS, and he presents a very interesting experience, which from the state management, how to use and optimize this new technology, and which were his experience during the COVID, where you know that the states had an important role in the response to the pandemic in a moment in which everybody realized that the state was essential to develop the environment of SUS. I give the floor to Sandro. We know each other for a long time. Sandro, you have the floor. Thank you, Renato. First, I would like to thank the invitation from PAHO. We are presenting this experience that we are been working in CONAS. Can you put my presentation in the screen, please? Before everything, I would like to clarify where the place of speech. I'm representing CONAS inside SUS that has 3 branches, management and a state management, as Dr. Rinaldo said. Everyone know how complex is SUS to respond to one system that is to over 40 million of people, and we represent a group of 27 states inside the SUS discussion. With the pandemic, in the peak of the pandemic, that we have over 240 deaths day, it demands an effort from CONAS to build a tool that could support to the state managers in this pandemic. So we try to organize information flows, not only strategic but tactical and operational. As Dr. Mauro mentioned, we have over 5,000 primary care that don't even have access to information. So that's a difficulty. We have been working to build a support network with intelligent inside the state secretaries, and to support the state managers to build a support to analyze the data related to SUS, not only the management, but the structure and the production data and everything that supports in decision making. Inside what we call to CIEGES, it's the intelligence center of SUS. We work in 3 central points: computing, statistics, and maths, and data science, that for us is the ones of the most important, and tools that we use in the organization of the work that the center does. And inside the science information, we have in CONAS a technical support. We have 3 technical assistants that help us in the health discussion in this specific theme. We have the ecosystem that we built inside the CONAS, Data Lake CONAS, GeoCONAS, Painel CONAS, and the network inside the panel. I'm going to talk very briefly about everyone. Data Lake CONAS has a data repository that's built from 2 data group. One is the official, the group of national system, and the other repositories is strategic data to the state management, are the ones that are not in the national system, but the states use or produce to make decisions. Nowadays, we have in our data lake CONAS over 23 billions of registrations, unifying all the 27 states. Inside this repository in strategic data and focus in the COVID issue, we could, in this discussion, to identify local problems that could turn into national problems and organize this data. I'm going to share the experience. Inside this logic, we could build and create technology not only to identify problems, but to produce, transmit, and use the data. So all the logistics and technology to identify the problem and feed the system, that could be a digital system or a spreadsheet, that we use these lights tools to do the connection and restructure and organize and generate the information. Here, to identify how are the data in Brazil, as my colleague said, this mention of systems that do not communicating and do not articulate inside our data lake, we could organize in a way where the health professional can have access more easily to those data. So in the current situation of the work of structuring this CONAS data lake, and to make decision easier in the local place. So we identified a challenge, which I think it's a very important point for us to discuss later, is the issue related to the transition of the generation of the workforce in SUS. Inside our work team, we have professionals that build their experience under data in analogical process. So when the digital era comes, we have the difficulty to use this data and the importance of data, how to analyze those data. So this is a difficulty that we found to go forward on this work. And another important point, under this team, all the results that have been happening in the clinical point of view, how can we translate this knowledge that has been generated so the front professional can understand, the community agent, people that work in primary care can understand, start to formulate the public policy that could be effective. And the other, thinking about in this parcel of workforce, we started the GeoCONAS, which is a geo-reference of all the analysis to make the view of the professional easier, so they can understand what does that mean. So we did a work in Fortaleza, in Ceará State, where the data that we could analyze, we identified where we have the highest rate of COVID for the sensory sector. And then we identified where the sensory sector is, the higher rate of transmission. And analyze the gel, we started to see the temperature places where we have primary care identified if this hot, where we have the deaths focus, so we can signalize to the manager that he can need to do a work, improve the work in this place. And in the work that we did, we have the COVID panels. It's a portal, group of analysis and graphics. One part is the public part that everyone have access. We have the QR code for the ones that want to access. It's available. And the group of data that's specific to the manager, where every manager has the knowledge of what is happening in their places. We can do that via smartphone or tablet, so can make easy the views of this data. And in the last work, in the context of the work that we do, is the creation of SIEGE's networks. That is a collaborative network with the State Secretary of Health. So in this work, we can map by theme. We did some work that I'm going to present, but we can identify by state what are the attributes that they have and the ones that they do not have. So we can identify the state that can support other state and vice versa. And we start to create these networks. And here we have an example of what we did inside the SIEGE that we call a SIEGE network. We linked and mapped all the cycle of the data, since from the HR existent, the producer of the information, the use of information, and identify the use of information. And also we could map and put in the panel. So we have these little maps of Brazil are by theme. The ones that are green are the one that could cooperate to other states, and the red ones are the one that need support with other states. And by every team, we had an analytical panel to identify the real needs of the state inside this specific team, and follow up with this logic inside the safety politic of the patients. Fernanda, that coordinates this area, cooperation work of Ministry of Health, and with the OMS platform, we could build a map, identify what's the advance inside every state of the patient. So we have an index to compare and identify which are the states that could cooperate and what strategic goal can be support or supportee by other state. And here we have a cohort. It's a general work that we start to build independent from the COVID work. I'm going to show the emergence of public health of COVID. So we also developed physical and social technology to build knowledge intelligence from the production of the data. And we know that CONAS have protagonism and was a key actor in the fight against denial and support the action of the Minister of Health and the states and municipalities to mitigate COVID in the pharmacological issues or non-pharmacological issues, and the assistance and protection. The first panel that we built for COVID, it was called COVID panel. Everyone remember that in June of 2020, we had something that the press called as a break of data, like the Ministry of Health present the COVID data, so that creates an instability, and at least then 24 hours we could build a panel taking data from the state secretary and create a relationship with the municipality in which every day at 6 and we until today we have this update. So this panel bring not only the number of case deaths, the percentages, where's the relation and the percentage of increase. And one thing that's curious in the COVID peak, the access to this panel was the one that was most accessed in the world inside the Tableau company. That's a company that managed that. And that made Tableau. So we can see the necessity to seek for those kind of information in that moment. And another important work that we did was the monitoring work of LIPS COVID from April 2020. We had an evolution of cases and deaths from COVID, where we had the sign that we need to have more beds in this emergency. We did not have any monitoring on this new habilitation. So that makes not possible to all the managers to identify the problems. Even Ministry of Health, because during the emergency they had the bed and had the difficulty to identify where the bed goes, because the requests came from all over the places. So we could build a monitoring system of beds in June of 2020, and this bed system that we built served as a founding to the municipalities and the Ministry of Health to have a more clear monitoring of the habilitations that were the admissions that were being doing. So we created automatized robots, and it was made by ordinances. And as the ordinance was published, we created a robot that opened the ordinance, created a logical model of feed of the panel, created the dynamic panel, and we feed the panel. And we also have a process that was very important. I think that everyone that saw the work in Brazil, that were the crisis of the kids of intubation. So since April 2020, SUS gives a warning sign. We have a very important point. CIEGES has a linkage with the communication area of CONAS. So everything that appears as news, we started to think about future problems that we can have in the future. So the lack of organized data, so we can create a flow of delivery of information, CIEG and CONAS, where we feed and help to have this make decision founding and identify in which place this problem could happen. And that with information flows to weekly information flows to the Minister of Health. So this is a technology that we could develop and could be replicated to other medicines and process that could happen in any system that doesn't have any data. So we can put that. We have several other experience that I'm going to skip. The vaccination issue and linked to the person that was vaccinated by coverage, by scheme and coverage. And another important work that we did is to analyze the rate of mortality, what COVID influence in Brazil. Just to take a look, you can see the curves that out of the pattern. So we have several experiences that we could build in the short time. And now we are working in this logic of post-COVID to identify the procedures of the primary care and the elective. What is the historical series? What is the period 2020-22 moment? What we need to go forward in 2022 to follow the normal course. Several studies that we have to put, and some lessons learned in the last 3 years by the urgency in situation. We could go forward in several process and analysis. We have to change all our pattern of work, not only CONAS, but CONASEN and Ministry of Health had to change the pattern of work. So the rhythm and the production of work that we had to fight is getting a size that's very unproportional from what we predict. And COVID teaches that the construction of information has only one way. You have to work with data. That's clear to everyone that work in SUS. But the fragmentation and the lack of access as the access of data not always the solution. So we cannot think that data is the solution, but we have to learn how to work with data. It's not enough for us to only work with data because sometimes it can make it difficult to make decisions. Some challenge. The production of and maintenance of this work demands a high cost, not only technical but political and financial. And inside CONAS, we have the whole support of the executive secretary and the current president for us to go forward in this work. And I think that's a very important point, but it's not enough to the technicians said that's if not enough to manage. So the automatized process of science data, AI, do not possess any cognitive ability skills to develop the creativity and SUS with its principles. We are under financed. So we need innovative process where only the human brain can find solutions to. So AI, as what my colleague said, it's important for us to work with, but we cannot have all on that to AI. We have a group of work that had the knowledge, the know-how, but we need the knowledge of them to make decision that we need to go further in the health situation. In Brazil, the challenge is not only a line, is to link the digital with the workforce that we have without any advanced tools. We have places where the primary care do not have any connectivity. So our great challenge is how we can have the digital technology in the analogical process where we live. So the importance to have this process, this technological access as a democratic form. And we need to go forward and learn how to work with that to generate values. The technology by itself do not generate any value. So we have to work with that to help the make decision of the manager. So this is the point that we are and how we can align all the digital process with the analogical process we have, how to reach this transformation, and this is something that we don't know. And this work that we've been developing, it's the contribution that we have to the situation. Thank you very much.
Thank you, Sandro. It's very interesting how an institution like CONAS has taken the responsibility for a series of tasks. But okay, this is not the purpose of this seminar. I would like to thank you, Sandro. And let's stop now for lunch. Lunch is served downstairs. It's a buffet. It's a fast modality of lunch. I think everybody can make the effort to have lunch in 45 minutes. In the afternoon, we're going to continue because it's important. Ricardo and Gabriel bring very important presentations about the ethical responsibilities of all of this, that they cannot be forgotten. and also the primary health care. If we can finish, if we can end this roundtable and at 2:30, we still have time to do the next table that is scheduled. Okay? Thank you, and have a quick lunch. And there's a good news here to Sandro because Japan is winning. Okay, lunch is served. Feel free to go downstairs, and we'll be back at 2 o'clock.
Good afternoon, ladies and gentlemen. Be welcome. So we are going to start our afternoon work. I would like to invite the invi- people to compound the table of this next table. We are going to 2:30 concluded this table. I ask you to take your seat and the ones that are going to take their places in the director table. Thank you very much. Be welcome. Take your seats. We are going to go back to our activities. We are going to take back the activity, having the presentation that are going to wrap up those presentations. You, Mr. Mediator, you have the floor. Good afternoon again. We are going to continue our table. Again, I'm going to ask you to the speakers, please, to watch your time. We have 2 more presentations today in the program. First, Ricardo Kuschenbecker. He is a HCPA risk manager and professor of medicine, Federal University of Rio Grande do Sul. And he's going to talk about ethical aspects and data governance, how to adapt the research context for data generation for the concepts of COVID through artificial intelligence experience reporting. And after, in the following, Gabriel Miller. He's a student of PPG Epidemiologic of Rio Grande do Sul University and also professor of medicine, University of Vale do Itacarí. And he's going to talk about primary analysis and validation methods for natural language process-based approach for semi-automated extraction of clinical test data from COVID patients in university hospitals. Because my text is so little, it's my age and the size of the text. I think that's a peculiar experience, very interesting and very innovative. I give the floor for you to share your time, 15 every each of you. Thank you very much. Good afternoon. A special thanks for us and then we are going to talk about how to process all this data, reliable data, to have reports and some articles to look in the perspective of AI, the point of view of legislations, and in the perspective of AI perspective. We have some challenge. The size of this country that has continental dimension. It's out of order here. I'm sorry. We have some challenge. First, we have several diversities here in the socio-economical and level and the pandemic cost context, assistential remarks, and regional difference in the point of view of level of complexity used and the register of this antenna. You have different cultures, issues, and the dimension of heterogeneity to recover this information in the electronic medical reports. So we have the database as to support it, but very dynamic. As Eduardo presented, the hospital vinculated to the university hospitals, which we are a part, and how the models can compete and look to the information in the context of millions of technical nodes, or we can review in an automized or semi-automized method. And the challenge means, in this perspective, to have EBSER, Hospital de Clínica, and part of this pool of hospitals in the COVID context until 2022 is to create a data hub to have safety in the storage of this information. And those challenge as how to build a safe and automatized information to generate data adequate to the legislation, to an anonymization method, to increase in non-structural data as access. PAHO and WHO has medical reports notes from the last days of discharge and admission. How we can look in the perspective of information that could be representative in the care of the disease and the outcomes that we have in these hospitalized persons in the context of COVID, and to generate automatized mechanism to extract data and to generate reports, and how to make viable ways of validation of this information. The machine, the learning machine, if it's possible, if they have parameters, and we have to be sure that the human look and the expertise and the machine can compare and have a reference pattern to see what the machine can recover. We had a committee of data governance because we have very complex data related. I've been followed by a fly. I'm sorry. All the governance mechanisms that are related to hospitals that don't have a biobank access need to work with the experience in biobanks, and data center could have data hubs for them to process the information that could be used to the publishes that material that we had and the scientific articles. I'm not going to detail that, but we had this committee to attend the requests of legislation, and all the effort was made, as I mentioned, with GHC, Hospital Conceição, EBSER, 5 hospital that were in the previous panel, and Hospital de Clínica, which had the support on this process. For us to attend to the regulatory process and the ethical dimension, Brazil is an international reference to protection of the research right. That means not only that every center have to adequate in the approval, led by Hospital Conceição in the proposal hospital. Every hospital that was a participant in the CONEP platform, Plataforma Brasil, could be submitted in their hospital the approval and the ethical and rights of research to make the study. And beyond that, we have, if you can imagine, to build this data hub, it was necessary to use cloud storage service to treat this data from receiving the information from every hospital. So these regulatory aspects had the general law of data protection and also legislation patterns from the European legislation about the protection of data to put this data in a strategic partnership that could be made from a BCER initiative, as mentioned by Eduardo, and activity that was made with iHealth Company International that has its headquarters in Brazil, that we developed the CHC Smart Health Connection that allowed us with a connection of providers that we could have AI techniques. Gabriel is going to bring that more detailed in the perspective of the validation of this information that we could process in structured data fields and also non-structured data. Medical reports where the notes of evolutions was tracked and mining to produce information that go in critical variables in the point of view of the CRF forms. So we took that and made all the work looking at the ethical and regulatory aspects and register patients with that anonymous data in a way that we can have this minimal security in the process of information. I'm gonna skip some slides. The systematic to mark the terms. The database was tracked 5 or 6 millions of clinical notes of electronic reports, CHC, using different informations and transform this information in lines and columns in the variable perspective, which is the main information that we have to have. Data Hub to build minimal dictionary of the terms using the techniques of neural language, so we can build a group of categories that say this patient has this kind of information, so we can translate this information that the kind of patient that the patient is inside this extract of data. You also use the virtual platform of AI, DataIQ, that allows us to organize this data and the integration between several bases, different mechanisms of integration information represented in graphics by these icons that give us an idea which were the processing that were used to recover the medical report information. And again, Gabriel is going to mention, but basically is the neural language was creating a correspondent language that the machine can identify that was made with the review of medical reports, and from that, the transformation in a process to have information. It was an automatized process developed to generate and transfer this information to from the hospital, extract this data and have a report. We are in the moment of technical support to change this information in technical reports. Some information just receives in this ebook that WHO just published, and scientific article that are disclosing to collaborate for we as hospital networks. We can produce information not only by the point of view mentioned, but the technical point of view which is relevant in the sanitary field. And obviously, that means that Data Hub can be as a pilot plan to the other institutional plan, and another things can be done to make possible that university hospital can join this process as an integration of the information that was presented in this table. And we have some challenge still. There are linked to this tool or this group of tool of AI. We are still focused in what PAHO and WHO did, which as the initial moments of the first days, the medical reports related to the discharge and the negative outcome, which the death. It's a big challenge to look at in time and go through all the care pathways to understand the pathways that the patients had, the costs. We aligned this process with Ministry of Health, CAPS and PQ in the methodological reports to look at the costs and think that we are going to manage the work. That's very possible. We have some additional stage which validate the mortality historical causes. We have one hospital that already does that, and they can compare through the different nurses and different institutions. The majority of the hospitals don't have that, but it's possible to align this technology and have the perspective, what we call as score of comorbidity. That's something that's predicted. And the other kind of report shared by different hospital, and the we have that organizing biobanks. We still are going to conclude that. And obviously, it has a cost to countries that have an average incomes, including the issue of the legal security. And we still have some challenges that are the research of research and a partnership between PAHO, Ministry of Health, and EBSER. And this initiative was possible because we did our part, so we can do the work as a whole, as a data hub to produce quality information that's like a bank in the sense of being a financial bank. And one future perspective that was presented here, so can take a look at the health surveillance, because the machine needs to learn in every situation and also can be capable to have data in real time. I want to mention a thankful mention, because this possibility was possible because PAHO from WHO initiative allowed Dr. Monica, Dr. Rosane Tarro. We could not be possible if the Ministry of Health had the financial support. In this sense, I thank Dr. Maria Batista but in behalf of SAES. Ostelar Conceição, in behalf Fernando Schalt. I could mention Bruno, Rogério, that review all the logistics of this activity. Dr. Giuseppe and Eduardo from EBSE, to have finance in the Portuguese language with a multi-platform machine. And I thank SHC, I have Leonardo Alegre, which I follow in the virtual way, Rafael Moraes, Natalia, linked to the university and has a scientific production of Universidade, EBSE, and this collaboration. And our group here of Hospital de Clínicas, Thiago Voz, Gabriel Miller, that did his work very well. We hope that could be a pilot project that have a seed to several possibilities. 15 years ago, the World Bank came and made a report that said the university hospital needs to show its value because they're very technological. So we need to look at that. We believe that this collaboration that the actors showed, we have some delay, but we are going to generate information to transparency, to the quality, assistential quality of these hospitals. Thank you very much.
Thank you very much. Thank you, Professor Ricardo. Now we're going to the young Professor Gabriel. He's going to explain again this magic that, because to understand the handwriting of a doctor, it's very difficult. Perfect. Thank you. Thank you, Professor Ricardo. Thank you, Dr. Roberto and the colleagues. It seems like magic, but it's not, unfortunately. It requires a lot of human knowledge. So, we're going to start my presentation. I'm going to try to be brief as a narrator. So it's a review of the processes. Fundamentally, we can divide it in a pre-processing, then it will have the processing through this artificial intelligence, where we're going to talk about analysis of correspondence, summary results, goals, and the conclusion. About the processing, we have to standardize these texts because many times the hospitals, they have different systems and it's necessary to have a priori integration. Of course, this is very complex because to export certain files, so we have to standardize them into a specific text. And we could do that when it was not available through methods and regular expressions, because the standard from the clinical text is similar, but it's different in different places. Then we have the processing through SHC and the post-processing. After we got the outputs of the SHC and we created the CRFs, the data bank that were can be analyzed. So about the solutions that were already implemented, we have text banks that were not compatible, a high volume of data, about 10 million 2 to 10 million, I'm not sure. I know it's a huge gap of clinical nodes, and this requires algorithms, standardized GPU, cloud processing, as Dr. Ricardo mentioned. Some nodes were modified, and in fact, there were some different standards that we could implement that in a very timely manner. About the steps, we could see the profile of the hospitals, and in the first step where we had especially IHCA and other institutions, but especially some that got into the validation process. As it was first mentioned, we thought about some strategies using structured data, those that we can find in a digitation because of the doctors serve, they have to serve quickly or they're overloaded and they don't feel this in a right way. So there is a concern about the accuracy and correspondence of some datas. That is it's happening and it was codified as SID. Besides that, some hospitals, for example, ours, they try to use strategies and regular expressions. I'm sorry for people at IT, but it's like a control F where you put amoxicillin and there's everything that is in Google. But if the text has amox, it's not identified, so it required us to have a big dictionary of data and it's not available. So we cannot use. So then there's the questioning and the need to be presented by the health staff, which is SHC, which is an algorithm that uses millions of clinical nodes and natural processing, and we can understand our register our reports and through classification of algorithms and neural networks. So there's a big question. It's not very clear in what's happening in the different layers. So how can we know if this information is really true? And then we propose a validation strategy based on causal graphs that thought about the instrumental variables, and then we could reduce for a validation strategy in the beginning and some variables that we thought epidemiological data, comorbidities, use of services, and closings. So we can have this minimum of 7 variables and we could generate information with higher quality. Uh, the more valuables, it's more difficult to generate this data. So explaining a little bit about this validation, there were chosen randomly 13 institutions that were in the beginning of the process, and basically the process was reviewed as it was built like a manual data bank, extracting terms, seeing what SHC was extracting, and creating variables. This is a detailed or strategy that we could see what was written in the text. So basically, SHC has a very interesting capacity to codify as present, missing. So we have this control F, for example, negafeb, as it appears in a lot of texts, for example, fever, etc. You have to return to hospital. So, and this would be codified as present, and this would not be true. Actually, this information is a possibility. In case this happens, SHC has to be validated regarding this. And if you see on my right, the outcome for this and the transformation in the tables. So for that, we use processes of similarity that are comparing, and you ask me, what is similarity? And basically, this is a code that shows this complexity to compare in my reference data. We have pre-established terms that were taken from our clinical corpus. For example, amoxicillin, amoxiclav, amoxi, and then you have amoxa, which is different from that. So we compare peer to peer, and if this value is above a certain limit, it's considered present. If not, it's considered lacking. So it is a very fundamental epidemiological matter because we need to use epidemiological indicators, specificity, and we have other indicators as F1, precision. So speaking a little bit about these limits, we use Hawk curves, and there is a very summarized description of how this process worked, and the rock curves for those more instrumental variables. I like to call the attention for the catheters because there is a difficulty to seek in the hospital resources the presence of high flow catheters. So we are having a high precision over this, especially in the instrumental variables. And we are using these resources as well. And we establish the thresholds, the optimized limits, which is established that proportional to the accuracy. And if you want to discuss, we can talk into more details. And we have tested our similarity algorithm, which is done after SHC. We're just trying the extraction. And now we have to test the creation of the table plus the IA. And then in this double extraction strategy, we have reached the values that are positive and quite high, especially for those categories. These are preliminary information. They are in the published step. So we're talking about confidentiality issues here. Also, we have to take care about the quantitative variables. There are many hospitals that do not have structured data about vital data, exams, lab results, and we have to use SHC to extract as well. But this is not exempt from validation, and it's not exempt of a pre-processing. We need to transform those possibilities, and we know that people from the clinical body is very specific, 10,000 whatever. So 10,000 white cells and all the existence of the cells. So comparing this to the extraction by SHC, and this is also an algorithm of regular expression of the SCCs, ICC, sorry, which is very elevated. Of course, some variables have lower values, but in these notes we observed less quantity. It was not a high quantity of nodes that use even lower quantities. So this was not the only challenge. Also, we have to consider that in many hospitals, they use different criteria for the inclusion of data bank. So, for example, there are patients that are tracked in the surgery and they got to the biobank. So there are different criteria to include, and this can lead a high heterogeneity level. And then, along with Rafael, we developed a classification algorithm based in the infectious disease about the different seriousness to know if there was this hack. So we teach the model to read a clinical note and classify it to see if in fact we're dealing with it. So we know that this is a very complex term. Many times through a clinical note is to diagnose a patient, and we have a high quantity of notes. We use 1,000, but we have the perspective to increase this more. And as Professor Eduardo said, each hospital has its own context. So every time there are new hospitals, we have to undergo through new validation strategies that are being developed. So we can talk more with these hospitals and show the first results about the curves that we have observed. These are the properties of these algorithms, and we can see there is a high convergency when the indexes they get closer after training steps to avoid overfitting, which is a great fear of those who work with this area. I don't have time to explain that. And also in the we divide this into the test set, and then we find the values that are really high: recall, positive, negative, accuracy, precision. I'm sorry. So, about the challenges that were solved, pre-processing was optimizing for each hospital. There are routines that are pre-established. It was just an adaptation. Most of these algorithms was already developed. Of course, we have to do some adaptation, but this is punctual. We have to do similarity and an extraction of continuous vars. We could improve this a lot, and we could use the similarity scripts and pair-to-pair comparison. This is extremely hard, extremely difficult, so we had to use GPU environments. About this, we had to list the hospitals with systems that were already structured, and we had to relate this data with structure and non-structure. This has to be done with great care, very calmly, because we can generate values that are very different. I will try to talk about the results very briefly. I just have 2 minutes more. In relation to results, we made a code book that was made available to the colleagues. It gives us a descriptive frequency, an initial one, for the person that is going to have a contact with the bank for the first time, especially when we talk about data governance and data requests in the data hub. So the person that will read that information. In the code book is available, and there is a quantification by the hospitals, by the epidemiological weeks all over Brazil, and these are standardized all over Brazil, and we can see the pattern here. Unfortunately, we're not going to be able to discuss this, and we consider a lot of comorbidities, other patients that were committed, patients that died, and evolution in the cases. So we observed a peak in the age that were lower. So we have to consider that the analysis of children less than 18 years old has to be done separately, because the linearity about the algorithms that we propose, it's not going to be followed. It's not going to be evolving from 0 to 90. We know there is a pattern of 0 years old with high rates of mortality, then a drop, then an elevation according to the comorbidities, and as of 18, if you allow me, something almost linear, and it's not like that. And then we measure time for the patient stays committed. We see these histograms, and we can think about what we said. There is a peak in this age rate, so we have to follow the linearity logs, and we can stratify this analysis. As we expect, the time to the event, the time of committed, the patient committed is also important. So we have to take a look at this, and when we observe, we have a high percentage of patients that were committed in 180 days, what reinforces what we thought about the past, about the long COVID, or people that need to be committed to the hospital again. Now we have an analysis of this robust variance, and we have to question the robust variance that take into account the different correlations of the institutions in the hospitals. And there were many models that are going to be verified, and the adjustments will be verified as well. And the analysis of constant review of the data. And here we can see this curve that we can have a profile for the patients, and maybe they will evolve in the 2 moments, they will evolve to death. So this is something that's going to be analyzed. Something that we observed about different times about the patients that were cold fired or not. And a very primary result, it is quite confidential, but I wanted to bring to you that we already have some results we using the Cox model and bivariables and showing the risk factors in an isolated way about age, sex, color of skin, but this lacks a more careful analysis. So this is very preliminary, so we don't have enough to analyze. So I would like to thank you. There are some pictures here missing. We couldn't collect all the pictures from our team and also from the new hospitals because we're very pleased that they joined us. As the professor said, it's like a bank. We need to be trustworthy, and I hope to be able to collaborate with you more. So would like to thank all the supports, Professor Eduardo, Professor Ricardo, Parro, WHO, Rosane, Dr. Roberta, Dr. Monica, without whom we couldn't, and of course PAHO and WHO. And it's almost like a doctor's thesis. If you forget to thank somebody, there is always a concern, but I would like to thank everybody, and if I miss somebody, I'm sorry, because without you we couldn't do this work. So thank you. I am available. Thank you.
Well, it's a little bit complex theme, so we have to have a space for any kind of comments or questions. The ones that are at the table can make any comments or questions. Ludovic, please. One question that I have, of course, that the project started with a number of institutions, and the question that I have is if another institution that want to sum the level of effort is uh, not so big. So what it's the requirements that you need to do that? I'm going to use a better term that is the view. Basically, because here the validation strategies were used to hospital context of adults as patients. When we add other ages, for example, children, that all the data dictionary is different. So we took a time to adapt the data. If we have a different language depending on the hospital, we have generalization which was very big. We have the local words. As Dr. Juliana said, it depends on the place, the acronyms. So we have to have effort to evaluate if it's in the same page as the hospital. When we see this high amount of the country, we have a minimal challenge. But in this initial process, when we need this process to be trustworthy, we need to have safety and security in this data. It's a study case which is primary, that's why it's not so fast. So we have a big generalization. Just one this process is going to decrease, so we can generate the learnings, but it's an interactive process. The database is going to be tracked with the process that every hospital have to tell if it makes sense, the expressions that are being used. And this process has in the context of Portuguese language. If we look specifically to what we are seeing, the COVID scenario, we are talking about a context of different environments. We learn much more than the machine learn with us. So this process is going to be potentialized, and we have a diversity of regions as the size as a continent. So the clinic narrative is different in the different regions of the country. To the innovation politics, the innovation, all of that are very important challenges for us as humans and the machine because of that. Thank you. My question is, they invert to reach the process we had to be founding. How much costs? How was the expenses that you had? That's a very good question. When we designed the second stage of the project, beyond the actions of COVID and post-COVID, according to PAHO, in the environment of the institution was to purpose to CNPq and CAPS, which are the supportive institution in university research in the country, and the Ministry of Health. We developed a strategy to make a procreation of the cost of micro cost in the adult patients with this respiratory disease. So from this possibility to characterize the incomes, we can look back and see how much does it cost in terms of processing. Data processing in the cloud, that means, Rafael, can you help me? Something about 3,000-4,000 reais by month using Amazon Cloud, which is nothing if you consider the enrichment that we are producing, but it's a high number if we have the incipience of the researches. The amount of data is so big, but the resource to process it, we are looking to the simple cost which the automatized process made in the cloud. But the cost generated by the team and the learning was not dimensioned. But it's our idea in the future, in the perspective to put that in a scale economy. Another question, if I can mention, we are being dedicated to reduce these costs, to change that to Python. We has a more efficient processes. So it's a stage that we are going to dedicate ourselves to decrease the cost and the time of processing. As we develop the scales, is the development. Just a comment related to the participation of another institution in this project, in the operational view. To want to join this project, we can communicate in this group, in the governance of this project. We have a committee that make this management, and through that we can put this new institution as a collaborator in this project inside our institution. Is something that is multi-focused, so we have to have another institution to join this work. So the ones who express the desire to join, we are going to put them on our work group. Thank you very much, Fernando. Just thank you for your complementation. Please, Mr. Roberto. Well, it's very interesting, everything that we planned here. Us what's under the surface of the health system that are related to ethical and operational issues. For example, everything that is linked to the surgery device, wait list, primary care. What happened to the primary care in zones where we have little municipality? The question is, can we make decisions with these three examples with traditional methodologies? When someone applies some minimal variables, or should we start to think and have an analysis more filtered? The ones that are going to take, we have that a way to gather that in these areas, what applied, but researches impacts the service. I live on that because we can think on that in the future. Just a comment about that. It's the storage of data that the university hospital have in the EBSER environment and the other hospital. The quality of this information is better than the private information, private hospital information. So it's something that need to process the information that can generate. We are facing an app that where the data inputs with extension teams has a very high enrichment, and the using of models like GAU allows the guidance that you are mentioning to support the make decision. For example, the Pioneer project that doesn't have even a decade, like in the example of Harvard in ICU. We can look not only to resource, but to make decisions in the direction of health-based in values, looking to outcomes, to added value that was add or not in related to the patients. Thank you for your question. We have another intervention here. Thank you. Please introduce yourself. Good afternoon. My name is Antônio Pazenfilho. I'm from the University of Medicine, the School of Medicine from Ribeirão Pedro. I would like to greet and thank you, congratulate you about how we treat and identify the level of reliability of every stage. Even though a little bit that I could work with the database that we received, that we are working with, we have some variables that have some gaps. It's very hard to work because of the level of occurrence that it has. Do you have any strategy to do a bag for them to auxiliary to develop in the development of AI? This is a big problem in this project. We have a situation if I have doubt I got the threshold of 80 and now I have 40. I can have samples of that and turn back to the hospitals so they could review this case and give its opinion and say what really happened. So you could put a third stage of validation, not only rely on AI, which is a very specific question, which was investigation issue in the American scenario. I'd like to ask if you thought about that and if that's possible in your opinion. And I think that's something that can have a follow-up of this work, and we can add in the to free this strategy. We already did that. We have been doing that. Dr. Juliana, Ariane, Patricia already start to support this project by mapping COVID. And related to post-COVID, it's a concern, as we mentioned, all the AI tool depends on the context. So when we talk about mainly in the nurse context, is very different from the admission context. All of that we measured was in the context of adult patients. So the answer is yes, we have been doing that. We are going to hire USP and University of Ribeirão Preto. As we saw, was a very quick process. And we intend to get this contact back and to have a specific team to post-COVID, because as we know, it depends on the context. The density of the informations and terms, I believe that in our college is pretty high, but is different related to other terms. I'm not from IT, I'm a doctor, I graduated in 2019, but I know the user of the system and I know what are the adaptation, more likely. And we need to train and we are going to have this return, but we need to take a break and pretty soon we are going to correct. Just a brief comment in this point, I promise to be brief. We have a context that there is adequate to take a look from this perspective is a context where all of them of the hospital or ICU to practice care that means teams to reviewing all the reports, because the data show that the register of non-structured data are more accurate than the structured data, because the interpretation of the data in the context of the research shows that the hospitals are ICU the whole time. So in this perspective that you said is using a disease that all the hospitals became in respiratory ICU. So they are correlated, the same team, the same cares, the same manifestations. So we have to separate, and this is another story. I just want to give a suggestion. I have been seeing this back validation issue, so it have to be included even with all the limitations. It could be done as part of the strategy of the other initiatives that we have. I really agree with your position. I know what happens. It's about 30 years, not like you, and it's a burden. I think that's back validation that have mechanism where you increase the accuracy of the reliability of your variable need to be reached. Thank you. Your experience, it shows what we said, something that we seek to increase the accuracy and proof. The communication with the hospital is very fundamental because they are going to help us and are going to be part of this data hub. And I see it as a unique opportunity to look at the Brazilian hospitals because sometimes we are strict to our places, closed places, and we do not know the reality. So this exchange of information is it's fundamental. Thank you very much. So we are going to close this panel. I'd like to comment that was Richmond. This theme was so important. We not see the students of the university. We see the managers of health, CONAS, CONASEM, are going to see they are seeing looking at this theme. I'm from the generation that gets frightened when we heard about that. As I go forward in my knowledge, it's not so magical and not so complex. I think it is, but I believe that in the future this is going to change a lot of the paradigms that we have. I get scared. It's going to be a technology that's going to allow things that nowadays we can even imagine. We cannot be as technology driven as the Americans say, but the fact is that we have such a strong technology and be guided by it. It's very comfortable. Can manage that. So I thank Gabriel, Gabriela, Ricardo, Sandro. It was excellent. And so, thank you very much. A round of applause and the table that answered.
Okay, thank you very much. We have concluded now our roundtable number 3. And now let's start our roundtable 3. According to the coordination, we're going to put the limit of 4 o'clock, and the game will be transmitted here in our big screen. Then we'll have coffee, of course, water, and then we stop. So let's go to our next roundtable that will talk about sharing experiences of primary health care in post-COVID, Brazil's contribution to the global clinical platform. Well, to coordinate this table, I would like to invite Monica Padilha, please. She is a Health Systems and Services Coordinator, Barro, who in Colombia. Welcome. Now we're going to invite the other panelists, Ana Cristina Vidor. She is the Manager of Epidemiological Surveillance of the Municipal Secretary of Florianópolis. Cleonara Schilling Mendonça. She is the Professor of Medicine in the University of the Rio Grande do Sul. Welcome, Professor Cleonara. Let's also invite Fernando Anchal. Fernando is the coordinator of the research sector, teaching and research management of the Conceição Porto Alegre Hospital Group. I think we have our panel ready. So, coordinator, you have the floor. Thank you. Thank you for inviting me to coordinate this table. I think today is the connection among research that we do and the response in the health services. So we would like to share experiences of primary health care. We're going to help the colleagues, and also we're going to start with the APS networks of Florianópolis. Please, the presentation, if you can put it in the screen. Do you have it, Vanessa? So technology is not our friend today, but let's go. Let's move on. Okay, perfect. Good afternoon, everyone. I am Ana Cristina Vidor. I am a doctor for the municipality of Florianopolis. I am a family doctor and I am the manager of the epidemiological surveillance. Now I got it. Okay, so the context. What is Florianopolis in this context? So we're talking about the capital of one of the states in the south of Brazil. It's a small capital for the parameters of Brazil. We have a little bit more than 500,000 people. We have a good um, IDH, and we have a good vocation for tourism and services. This influences the risks of the city. Florianopolis is one of the main touristic destinations of Brazil, national and international. And I have shared some pictures to invite you to visit our municipality, but this makes us to be an entry door for new serious disease because this is a touristic route. We have gone since 2020 many stages of the pandemic. Unfortunately, it's not over yet. We've had more than 202,000 cases and a little bit more than 1,000 deaths, and it has been quite distributed in the period. In 2020, we didn't have any variants. This data is specifically about Florianopolis, but we had the original variant. We didn't have vaccines, and we had a lethality rate of 0.84%. In 2021, it was our worst year, the year that the Delta variant came strong, and we had one of the largest vaccinal coverages, more than 82%, and even so, we had a lethality rate of 1.4%. And now, in 2022, we have this red in the graph, and it's referring to Omicron variant. And we have a vaccinal coverage of 73% of the population among adults and adolescents in this with a booster shot, and also a lethality rate that has dropped because of vaccines and because of Omicron characteristics that are different from the other variants. So in 2022, we have a 0.18 lethality rate. So we're not working with primary health care in Florianopolis, and I'm going to explain you why. Florianopolis has 49 healthcare centers, primary healthcare centers, with 162 teams for family health care. Also, we have the NASF that support the family care, 4 clinics, 3 basic unit service facilities, 3 psychosocial centers, and 1 center for remote care service. It's called Alô Saúde, that started working when the epidemic showed in the states and in the municipality, and we do service through the phone. All of them use a single electronic registration, so it's possible to map the trajectory, the journey of the patient using the same database. And the service of surveillance for the lab, LAMUFI, and the epidemiological surveillance, they also use the same electronic registration, the same electronic system. And we had a difference in the information system since 2020 to compile the data for COVID. We started to use headcap that in less than a month collapsed due to the amount of cases, and the other system was not ready, so we were without a system for some days. And if this happens in our municipality, it looks like days without it, so we didn't have any data bank for COVID. And all data today, all the cases of COVID that were confirmed in Florianopolis, they have an investigation report in our system, and we use this to follow up on the cases for COVID-19. So even the patients that were notified by CVEP, they are in our system, in our electronic system. The cases that we discover only after that are also in our electronic system. So because of that, in Florianopolis, we opted to use this data bank to do the follow-up on the COVID-19 cases. Florianopolis was invited to participate in this project. I thank you for that. It was an honor for us to be part of this. And we were invited in the second half of 2022. So for us, this was a short run. It was a very hard thing. It was a challenge. And we used the material for post-COVID, and this was designed to be prospective. And a lot that was asked there, it makes sense because there was not a possibility for us to do, because there was a protocol to follow after COVID. In Brazil, doesn't exist in the hospitals. People, they seek for the health services spontaneously because they have another complication, another illness, or they are identify those patients that have a condition that can be associated to COVID-19, but in a very usual way. There's not a formal protocol. So, as we thought, how do we thought about that? We thought about doing a retrospective court based on this electronic system, getting all the non-hospital cases, because these that are not in the capital, they use other information systems that they can get into this study. We got all the cases from the first case was in March, so we got since the first case up to now that were notified through any health service. So it can be notified by the hospital, by pharmacies, by any system, and that they had any registered service between 4 and 8 weeks after COVID-19 diagnostic. So this will be a follow-up since the first care. So this service can be due to any cause, maybe for a vaccination, for a suture, or for a follow-up. And this service, it has a consultation, it has medicine delivery, any contact for any reason generates a service, and this was the one that we consider as a study unit. So for each person that was identified, that was part of the study, there was a file that was filled with the data from that consultation, and each new contact generated a new follow-up file. And then we had another difficulty, that is to identify the cases of reinfection and how we're going to see what is COVID, what is persistent, what is a COVID again. So the for reinfection, official reinfection, the patients should have two samples with an interval of 90 days between them submitted to genomic evaluation. From the point of view, from the logistics point of view, this is practically impossible because we see very low cases of reinfection, but we need to acknowledge this in our bank. And these cases were included, we evaluated, and we decided to choose, along with Pajo, to see a new episode of COVID with an episode of at least 90 days apart from the first one, and that was confirmed through lab or PCR or antigen test. So this was the definition of reinfection that we have adopted, and the date for the non-symptom cases was considered the date of the collection of the test. As it was said many times, to extract this information, we need to inform and train the machine. And we needed to learn this first. So we opted to select some variables because the file is immense and we wouldn't have time to work with everything. So from the point of view of structure fields, basically we focus on section 1.2.3.4 and the ones related to reinfection 2.2 and vaccinal situation 2.3. So all the vaccines that were applied in the municipality of Florianopolis are in the system. And I skipped one. So to identify the data, it was taken from this system, the CELC, which is our electronic registration, electronic system, creation of queries, SQL, extraction of the data, the screening of the data, processing of Python, and the files. For those fields that were not structured, we focus on section 2.5 and just for some symptoms in this section, and section 3.5 just some complications, cardiovascular complications. I'm going to show you some in the results because for this process these were conditions that were easier to define and that probably had less affected people, so we could test the model, and then after the adjustments we could go to more complex symptoms to define what is a myocarditis. It is much easier to find this in the patient's record than hypertension, to find out if there's a hypertension post-COVID. All patients have in some moment of their lives hypertension, so this is much more complex for us to work with. And then in this process to capture information, we need to define other complications. And for the 3.5 field, we had to find out what happened after COVID, because we have to identify, for example, if the arrhythmia is after COVID, for example, if it's due to COVID or not. So if that complication was present in the first consultation, we would consider that as a pre-existing condition, because given the date that we needed to, we considered that this was a pre-existing condition. It was not a condition due to COVID. And in the first service, in the first consultation, if the condition happened and happened in the other, and then yes, we would consider this as a post-COVID. Or if didn't happen in the first consultation and neither the other ones, it would be considered as non-existent, and 3.5 would be marked as no. So in this strategy, through the same order that others mentioned, we had a pre-processing that was really important. We're working with a heterogeneity of data of people, patients that had COVID and never went to primary health care because of that, but they went to hospitals because of other things. People that are going to the hospitals because of other comorbidities. And in the system, we have some different registers from patients, from professionals. So this pre-processing um, enables the uniformization of the text, and this is the first stage to be able to work with the database. Then the ranking of the relevant text through a search engine. We're going to show this in a moment. And also the labeling of texts. Within the logic to create a system, so the system can learn with the language what were the characteristics. We have to control the time. Sorry, you have 2 minutes. In my watch, there's still 3 minutes. Okay, but I'm almost going to an end. And then we have to teach the machine how to work. It was described by other colleagues, but we could work with the systems that we created, the variables, the keywords. We identify if there were similar groups, if there was a tag or not, and this process was repeated many times in the sense to try to make the machine identify what we wanted it to identify. This was the result. We signed the contract on July 27. On August, we could sign the contract with the Federal University of the state of Alagoas. Dr. Kleber is here with us. He developed the work. And on September 5th, we had to deliver a preliminary report. Then September 28th, we had access to the data bank through authorizations, and they had to understand the bank because we don't work with back end. We needed to understand, and the final report was written 2 months after they had the contact with the bank. So it was very fast. It was more than 7 million texts analyzed, and the patients that had the criteria to have a certain consultation between 4 and 8 weeks after the diagnostic were more than 28,000 patients, and they have generated more than 400,000 services and consultations, and we identify 17.1 reinfections. These are the structured data. We could get a nice nice amplitude of results. Some data is more identifiable than others, like weight and height. So the amplitude of the structured data was very satisfactory. And for the non-structured, we will still learn, and we could identify, based on the criteria that we have identified, the number of complications. Not validation, person to person, we could do it. And we know that if we are going to review the files, so there is going to be a difference. So we could not even validate and see what is the precision, what the accuracy of the system is. There are many limitations. The record itself, because they don't differentiate the conditions among people. So if the files are blank, maybe they were not asked. So the quality of the data in the files, we all know they come in different ways. Limitation of the capture of information in this standardized period. So if the person had a different consultation, it was not included in the study. and people that came after the period or in the private hospitals. But we have an immediate use product that in this moment, this tracking with people that probably have the complication post COVID, they are already validated. We know that they have to be validated, but we can give the list to this clinic. We can search these patients. We can do the validation somehow, and we have to provide the care that this patient will need. And the next steps to continue in this process, so to teach the machine and learn with the process as well, we have to apply these for other outcomes. The concentration of the linked analysis to the type of professional we are evaluating since the screening until another point. If we focus in some professionals, maybe we could have a higher accuracy with less effort. The possibility in the same electronic file to explore other fields to qualify the information. In some cases, we have patients were 16 years old, and in some files it says that they didn't even have 1 year of study, and this is not true. So sometimes we took a look at patients that who didn't have any year of study, and they were spotted as early years. So if we had some time to explore data, we could have a higher quality of these, of the filling of the data. And these are my contacts, mine and Professor Crowley, and we are at your disposal.
Very interesting, the work that you did. I cannot make any comment because of the time, but we have to try to reflect on this information that we showed. Now we are going to have Cleonara that can share her experience with us. Good afternoon. It's a pleasure to be here. My place here as a coordinator of one health unit, which is linked to the hospital from Porto Alegre and use the same information system. What Fernando told me at the time that we are talking about primary care was that AI in the data mining could be used in the primary health service. But in fact, obviously, what we had this kind of issue to use the data post-COVID or long COVID. We had a very low response that I brought to you, which I think that's very important because our contribution is exactly the contribution to the impact in the community basis. What the social pressure in the high COVID for the one that were not hospitalized, but the post hospitalization and with respiratory disease that come back to the primary healthcare. So it's our responsibility. I will show my presentation on the screen. Let's go. So I talk about a service. Talk about a service of a unit in the social center with a big population, over 40,000 people, that historically has between 18 20,000 patients being attended by this unit with the pandemic that was higher. And the first thing that I would like to call attention is, as Anna said, we had 3 pandemics depending on which variant. And one of the conclusions that we need to certify is that Omicron in 2022 don't doesn't have patient post-COVID because it's a cold syndrome that has a big impact in the service, but don't doesn't have any complications. So the data that we took are from 2021, the 811 patients, over 5,000 that have respiratory symptoms that were consulted. The other bars in this graphic, one service on primary care different from a hospital that became a huge ICU. I tended to the respiratory syndrome. In the primary care, we had a higher number of tele consultations that were the first bars in 2022. That are the yellow one is from January to July of 2022. We have a big number by telemedicine, and the second bar are the on-site attendant consultations that we had with several other alternatives as doctor's note of medicines has a huge impact in the service. So referring to beta, an average of age of 55 years old, I have the most common symptoms, which are headaches, myalgia, sore throat, and close to 30% we have another problems which is complete different from 2022, with the main symptoms were the respiratory symptoms, which we didn't have any coughs and unsaturation from what happened in 2021, that what shows the graphic on my right. And this is something that we tried to gather the data. Almost 35% of people had the five main symptoms from 2022: cough, headaches, fever. We have two or three of them, almost 100% of all the cases. The previous disease, 25%, with cardio disease, 7%, with diabetes, and 11% with asthma. And to 2021, 10% of the patients were the patients with the percentage that of the patient that we went through to 2022. This is a telemonitoring. It's another project where all the patients that went home with the COVID diagnostics had a follow-up treatment. We have an average of 2.7 of efficiency to monitoring these patients by phone, and the results are very efficient. Almost 3 calls to talk with the person, but only less than 1% was take to the follow-up consultations. What is the first thing that called the attention when I looked at this data? It's a very high pressure of the society. I'm not talking about long COVID, but 38% of the patients had 1 or 2 consultations, and approximately 60% had 3 or more consultations. Mute patients, a big return with the respiratory symptoms of the patient. So this is the result of the data mining. We found 13 patients. 2 of them didn't have any post-COVID symptoms. It's very interesting to look at that as a case report. So it translates in the situation of the bad patients. 40% on the symptoms with the mental health historic report, half of them with pain in the bones, and half with respiratory issues. All of them needed physiotherapy, and some of them needed another specialties as psychologists and nutrition, and others that had neuropathical disease needed to have medicines that in SUS has a different flow. They are paid by the state secretary. So that generates in the healthcare service several additional consultations to accomplish the requirements of scales of pain to have the medicines as gabapentin where these were indicated. So in a general overview, as I said, one thing that caught attention was that our expectation was that the patients that were admitted will show, the ones that had admission, 4 of them were admitted, but outside of the hospital. Another assistential pressure if each patient meant to 9 consultations in average, not only primary care and another specialties. And what I refer before, the issues of the other services. In the last, this prevalence, if we are going to talk about the all 800 patients, was 1.3%, these 11 patients. So this one thing that we first learned, maybe in the primary care, the long COVID and the subsequent symptoms has a prevalence that's lower than the 10% of the patients that still have the symptoms after the 3 weeks. And the other question is, in fact, this low COVID are about patients that had this respiratory syndrome. So this is the first question that we need to answer, that the patients that were not admitted, we are going to have persistent symptoms in a lower prevalence. And the low prevalence, the size, the amount of patients that are consulted in the primary healthcare, that means a very high assistential pressure in the service. And how much the previous conditions, the psychic suffering like asthma, are related to what we call long COVID in the primary healthcare. So maybe we need to propose another models of study, for example, control case with patients with similar mortality, and what happened with them between the ones that among the ones that didn't had any registration of all the patients that were consulted. And I think that the idea, I want to thank Rosane to attend this demand for us to study in a better way the situation of post-COVID in the primary healthcare, because I think it has a huge impact in the health system, especially in the Brazilian model. We need to produce evidences, mainly because of the social vulnerabilities, be poor, unemployed, multimorbid, are related to symptoms post-COVID this is the place for us to evaluate this kind of situation, primary health care. And the importance of physiotherapy. Only this analysis, so small of these cases, shows that the new technologies are showing to be incorporated in primary healthcare because some of these 11 patients were discharged, they got better, and a good part of that had acupuncture and another technologies to all kinds of pain, muscular, neuropathics. So we have a big challenge to the service in this moment. And all of us are very committed to show evidences in and the nurse patients. So we while we are doing this evaluation, we realize the size of what we produce in this time. I want to end it with a quote from Gonçalves. If it was not for SUS, it was something that went wild in the pandemic time. Thank you very much.
Thank you, Cleonara. I think we have a lot to comment. Speaking about the organizers, maybe we could have some minutes, maybe tomorrow, to deepen the questions that we have today. And now we're going to ask Dr. Rangel to share with us his experience. Thank you. So first, I would like to invite Dr. Ricardo. I'd like to thank you everybody for the opportunity to have this type of work and to form this research team to translate this the country's heterogeneity that surpasses the regulation aspects, quality of data, quality of services, and even ethical aspects. We have different characteristics, complementary characteristics, and I think this is what makes all this works. And we work with extreme deadlines that WHO and PAHO give us. So, my presentation, please. Please, his presentation. Thank you. So, I would like to share the experience to primary health care for the Conceição Hospital Group. These are not just hospitals. We have centers for family health. We have PAD teams. We have the street doctor's office. So we have more than 1,500 beds and more than 10,000 employees. So it's more than 60% of the municipality of the state. In the Conceição group, we have more than 1.4 million consultations. So we're going to talk now about the community health unit, where we have 105,000 people. They are followed by prevention programs or health treatment. So we have this complement to the health sector. We have the data. And about that, we have our electronic register, our electronic log. That is the GHC system, and from that we could identify 27,000 patients that were served after COVID. 17,000 of these patients, they were served by us and they were already in our system. GHC works with care lines and community health the same way. We work with data and pre-established protocols because the pandemic put a way for us to think about new forms of care, and our basic care unit did a work towards that. And about the pandemic in 2021, the teams, they said that the challenges would be to organize the flows, to establish protocols, and they saw that demand was decreasing for chronic disease, and what post COVID would bring us. And we have seen this. The consultations, they were dropping, and they came back on 2021 and even more in 2022. The same way we say that this, for the consultations for hypertensives, for asthmatic patients in 2019, these happen in a certain proportion. They lowered in 2020, and after that, of course, they increased again. We conducted a study with the patients post COVID, so we have a different context about that, and we could follow up the patients, especially with neurological and psychiatric disease. And we know that we are seeking for matters of fatigue, headaches, other issues of mental health, because these are important. And we have seen that our patients, the post-COVID patients, in the study, more than 200 patients that were followed up throughout 6 years to a year, they had more comorbidities than the literature said. Most of them were male between 40 and 49 years old, and they had basic comorbidities. And in this follow up, we could see that depression, anxiety, they had high levels of incidence. And there was also post traumatic syndrome in a certain degree. So this is what we have in our reports of preliminary results. In this context of the organization of the system and guidance to the patients, we have organized ourselves, and we have put this into a primary health care booklet, and to identify the main signs, how the patient can evaluate this, how can he see the signs in the HAS, in the severe acute respiratory syndrome. And we have made this booklet available for those that wanted to use and adapt to their realities, because these points are peculiar and similar in some points. So this is the fastest way I could send my message, because I had very little time, and I would like to thank you. And in the last 5 minutes before we end this table, I am available if you wanted to discuss something. Thank you. Thank you. With this challenge, we pose this challenge, but let's open to comments now. I know that you want to watch the game, but I think nobody? Roberto, please. I just wanted to thank everyone. It's very interesting, but really, I think that we could talk tomorrow about the experience. All the experiences are very interesting. So I think that we should leave space tomorrow to talk more, because we are rushing a little bit. Thank you. I would like to make a comment about we're listening and hearing today. We have some common points with the possibility to have single logs where the level of the primary health care and the systematic registration of patients can be something that will enable us to accumulate a lot of knowledge. So I think this is something that we learned fast, And I think this generates the possibility to generate data and to analyze the data, not just in the log, but also to improve the care of people. So, in this sense, I would like to comment that during the pandemic, there was a suspension of services all over the world where we had to stay home. And there were many complications. And the health system, they didn't have the capacity to maintain both spaces, intensive care and primary health care. But I think that Brazil is different in this sense. So we are very happy with Roberto's suggestion, and we have to prepare ourselves, and tomorrow we'll talk more about that. Thank you very much to all participants. Thank you. So in the next minutes, there will be uh, infrastructure so we can follow the game. And tomorrow we'll start at 8. I think that for the next 90 minutes we are all Brazilian, right? Thank you and see you tomorrow.